Good. Good afternoon, everyone. Welcome to the March Governing Body meeting in public. As ever, it's not a public meeting, but members of the public are on this call for the first time. It's being held virtually, so we're all spread out across the county and probably outside the county as well, actually. As I've just said, this is a Teams meeting. Members of the public are on the call. It is being recorded as well and will be available on website at some point. Can I remind everyone that if you're not speaking, please keep your mics and your cameras off. A reminder to the members of the public that are on the call that there will be a chance for questions to the governing body at the end of the call, and we'll discuss how we're going to, or advise how those will be done once we get to that part of the meeting. Just a reminder to those presenting and to other governing body members that papers should have been read. I'd ask that replies to questions and introductions to papers are kept succinct. This is a very full governing body, not just the public one, but also the confidential one, which we have afterwards. Just a reminder that if people could refrain from commenting in the chat rather than the normal put your hand up and then come in when asked to, partly because it is being recorded and we can't record those chat comments. So without further ado, we'll start with apologies.
Sorry, yes, we've received apologies from, there seems to be someone with a mic on. Heather Johnson, Paul Gallagher, Mark Seaton, Asif Ahmed and Alison Shearman.
Okay, jump slightly here. In terms of chorusy, Paul.
All CCGs are core at bar, Stafford and Cannock, Stafford and Surround, sorry, who are not core at clinically. Dr. Ahmed is not here.
Okay. How are we going to sort that for decision-making purposes?
For decision-making purposes, two options. Chair's action taken by Paddy to then be communicated to the quorum members offline or at the next meeting when that's quorum, or for Paddy and Asif to review the decisions taken offline to make it clinically led decision, either or, whichever is Chair's preference. Okay.
Paddy, do you have a preference?
I'd suggest that I have a conversation offline with Asif. He and I have already discussed that, so happy to pick any decisions up and then feed them directly back to Paul.
Okay, fine. Declarations of interest and actions taken to manage the conflicts. I don't think on this part, apart from anything that's been declared, there are any additional conflicts of interest. If anybody has any, could they declare them now?
Hi Chair, for some reason my conflicts aren't recorded on the register. I've no conflicts of interest and my training's up to date.
Okay, thank you, Sue. Just record that in the minutes for purposes of managing conflicts. Okay, minutes from the meeting of the 28th of January. Should that not be February? Okay, so the meeting of the governing body meeting in common in public from 28th of January. I'll do a page turn, so page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I don't remember it being this long. 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23 and 24. So if we're happy with those minutes, I'll take silence as assent. We'll sign those off. Action list. Which there were no actions from the 28th of January. So move on to the first paper. So we're going to have a little bit of a change round in the agenda to accommodate people that are coming later to the meeting so that they can present them formally. I'm going to start with the standing items, then the items for ratification, items for information and the update from subcommittee chairs, and then approval, discussion and assurance papers at the end. So if I can ask Paul Winter for the COVID risk register.
Okay, thank you. I'll just introduce myself. I'm Paul Winter, Deputy Director of Corporate Governance, Compliance and Data Protection for the 6 Staffordshire CCGs. The risk register presented today is the latest update of our standard COVID specific risk register. Just for members of the public who maybe have not been in attendance, the full corporate risk register has been temporarily stood down whilst we're in pandemic response. So this is the update of the risk register from each of the operational cells that form part of the Incident Coordination Centre and how they're managing all issues in relation to COVID. As stated in the front cover sheet, there is one risk that's had an increase in risk score, which is about restoration and recovery. Slight increase, was already a high risk, on up to 16 from a score of 12. There are no new risks, closed risks or decreases in risk score since the last governing body meeting. So over to members for any questions.
Any questions for Paul around the risk register? Neil?
Thank you, Chair. Neil Chambers, Lane Member Governance for the CCGs in the South. Paul, can you confirm, please, that the risk register will be carried forward into the new year with the risks transferred across?
Yeah, well, yes. I mean, obviously, I think we're assuming that COVID will still be happening in the new financial year, so the COVID risk register will be it until such time as we stand down from sort of level 4, level 3 risk, crisis response. So it will carry over into the new financial year. At the point we are stood down effectively from incident coordination, pandemic response sort of mode into normal BAU mode, then we will populate a new corporate risk register with a review from all lead directors and prior risk owners to see if the risks that have been mothballed for the last few months are still pertinent in the next financial year, and then start again from there, as it were. But any COVID risks that kind of have a post-COVID enduring effect will obviously appear on the corporate risk register as well. So kind of yes and no answer, really.
Well, first time mute myself. Hope this isn't an omen. Anyway, any further questions for Paul on the risk register? John, Howard?
Yes, thank you, Chair. It's the risk that's increased, Paul, the workforce modelling, restoration and recovery. I wonder if someone could provide a little more detail about why we have a lack of clarity and if that's going to improve anytime soon so that the proper mitigations can be put in place.
Yeah, sure. I think probably default to a mix of Sally as lead director for the workforce cell, effectively, and Cheryl as lead director for the operations cells. To give you an answer to that, if I may, John.
Yes, sorry, I should have introduced myself. John Howard, lay member for governance, Stoke-on-Trent, CCG. Thank you, Chair.
It's okay, John. I think I forgot to introduce myself as well. So, just for those who don't know me, I'm Dr. Gary Free. I'm Chair Cannock Chase CCG and chairing today's meeting. Okay. Any further questions for Paul on the risk register?
Do I just need to step in there, Gary? Really, because the question that was raised was by John was what assurances have we got about this moving forwards? That score was increased as we went into this current lockdown, and I think we're probably getting to the point where we need to review it. That will have to be done with all the directors in a start the week meeting and discussed at EMT when we've done that, before it comes, the exec management team, before it comes back to the governing body. So I'll take that away as an action to do.
Thank you.
Any further questions, comments from members? If not, we'll move on to the board assurance framework, which Sally is yours.
Yeah. Okay. Thank you, Chair. So this is the latest version of the board assurance framework. It is updated by the senior management team on a monthly basis, and a line-by-line review was carried out in February by the executive management team, which includes the chairs and clinical directors from the north, the medical director. It gives us an update on the risk profile against each of the defined corporate objectives, and governing bodies should use it to make an assessment of where they think each objective is at the moment. It is refreshed each year, and I know that David Harding had asked at one of the previous governing body meetings as whether we could look to a more 2-year cycle, because some risks we are just not going to be able to achieve in year. And if you look at where we are now at the end of March, we've got 4 of the strategic objectives on target for delivery by the year end, 2 are not, and 1 is completed, so that there's merit in that. Unfortunately, these 6 CCGs won't be around after midnight on September the 30th this year, so a 2-year cycle is perhaps a bit optimistic at the moment given the lifetime of our CCGs, but it is here. We are having a workshop with governing body members at the end of April with our new internal auditors to go through this in detail and look at what we need to take forward as we move into the new year.
Tim?
Thanks, Chair. Tim Bevington, lay member, Stoke-on-Trent CCG. Really, so it's just on your last point about obviously the changes in the structure and the move to the merged CCG in October. And I was wondering from a board assurance perspective how we're going to review that progress at board level going forward, whether it would form part of an interim framework, if you like, or whether we will need to have a separate framework or risk register to address our progress against that.
Do you mean the progress of the board assurance framework, Tim?
No, really the interim, the progress against the steps we will need to make to get to a merged CCG, because it is a strategic objective and normally it would fit as part of the board assurance framework.
I'm with you, absolutely. We had a workshop with Audit Committee members this week with our internal auditors, and that question was raised because it's Audit Committee's role to review the processes that we're undertaking for something as significant as a merger. What we've put in place is a monthly meeting of Audit Committee over the summer while we're going through that to enable them to do that role, and Audit Committee will report back to governing body on how that's going. I'm assuming during the summer, but that's what I think will be happening. Okay.
Thank you.
Peter?
Thanks, Chair. Peter Dartford, lay member for Patient and Public Involvement for North Staffs CCG. Just to point out that there is an inconsistency between what the reference to the progress on objective SA2 on the cover sheet and that's described in the BAF itself. I understand from the respective director is that what's in the BAF is the accurate situation, and that where it says complete in the cover sheet, that should be on track. Thanks, Chair.
Okay, Peter, thank you for pointing that out. And the relevant director, I think, for that is Jane Moore, is it? So, yeah, okay, thank you.
Okay, thank you, Sally. Is there any further questions for Sally on the board assurance framework? Fine, good. Move on to the chair's report. 6 chairs. I'll assume that everybody has read the report. I think that particularly given this is a public meeting, just draw attention to a few things, one of which is the vaccination programme, which is ongoing and will be discussed later. The other is around GP access. There's a couple of bits here. Firstly, general practice is having to do things differently, as is everybody, because of COVID still. This means that things are a bit slower. However, we are, in terms of numbers, delivering the same amount of care as we were previously. The way that is accessed is also different, and we realise there's probably some work that we need to do as CCGs in order to ensure that patients still manage to get the service that they need, particularly in terms of communications and about how that's happening, and also around ensuring that through the next phase, restoration and recovery, that we continue, because we haven't actually stopped doing managing people's conditions, but clearly there is now a backlog because of the problems that we've had, and we are I hesitate to say beginning, because like I said, we haven't stopped it, and we are now getting back to somewhat normality. Some of those long-term condition checks will be prioritised. We'll talk later around the COVID numbers. Clearly, they're going down. We can see that through the information that comes out. The only other thing that I'd bring to the attention of everyone is that we've had a system-wide frailty strategy. Frailty is a funny thing. A lot of people don't like the word frailty, partly because it implies a negative state, and essentially what we need to do is develop a living well service. So encouraging people, residents, patients, to live healthy lives, live healthier, and in that way live their lives more in health than in ill health, which is one of the problems at the moment. Clearly COVID has had a bit of an impact upon that, and actually that has hastened some people's movement from healthy living to less healthy living, if I can put it like that. And that we will be taking steps to address that. I'll stop there. If there's any questions from anyone about the contents of the report. If not, I'll move on to the Accountable Officer's report. Marcus.
Thank you, Gary. You ran through that very quickly, so I better get to my place on the agenda. As Gary said, I will take the report as read, but given we are meeting in public, there were just a couple of things I just wanted to point out and say a few thank yous as well. So just draw the governing body's attention to the financial position. So as you'll hear from Paul later on, we are on track at month 11 to deliver a break-even position, if not a small surplus. But whilst a lot of that is down to additional monies received to help us manage our response to the pandemic, despite that, there was still some risks to delivering a break-even position. So, the people across the organisation and the wider system will work really hard to make sure we do actually bring in the position at break-even, which is what we were required to do. So that's good news. Just in terms of the mental health investment standard, I've got it in there as achieving it for 2021-22, which I think should be 2021. So my apologies for that. Just in terms of the COVID position, as Gary said, a much improved position. At the moment, our rates per 100,000, the rate nationally is 55.3. That's the rate for England, 55.3 cases per 100,000. The position for Staffordshire is at 65.3, which is just less than half of what it was a month ago. And the rate for Stoke-on-Trent is 77.2 per 100,000, which is about half of what it was a month ago. So a much improved position, largely as a result of lockdown and the national restrictions. And we're really beginning to see the impact of the vaccination programme, which we'll talk about later on the agenda. The rate of decrease is dropping off a little bit. I think nationally there's only been a 5% decrease this week compared to last week across the whole of England. So an improving position, beginning to slow down, and we would expect to see that because with the kids going back to school a couple of weeks ago and the further easing of lockdown restrictions, we would expect to see that have an impact on cases. I think the good news is we're in a much better or a very different position now than we were when lockdown restrictions were eased previously, given that we've now got a very significant proportion of our population vaccinated, and many of the people who would have ended up in hospital, would have got ill, required medical attention, potentially would have died, are now protected by the vaccine. So whilst we may get a slight bounce back as restrictions are eased, we're hoping it won't be the extent we saw last time, and we certainly won't see the consequent impact on the NHS services and beds. Also, just in terms of beds, our bed position across all of our providers is much improved. And if I can use, say, universities, hospitals of Derby Burton as an example, sort of around about the sort of Christmas period in the depths of winter, over 40% of their beds were occupied with people with COVID, and that's now down to about 4%, just over 4%. So 10% of what it was. And I think UHDB was the second, the trust with the second highest number of people with COVID in a bed after the University Hospitals of Birmingham. A big improvement as well at UHM. Most recent figures are around about 6% of the people in beds are occupied by people with COVID. So again, a much improved position, and we're also seeing significant improvements in staff sickness. We're really concerned around the impact of COVID on our workforce and staff sickness rates, which really made things a lot more difficult for our colleagues at the front line. Again, that is much improved. Again, for around about 2/3 of the people off sick with COVID down to about 1/3. So much improved position across our hospitals and also in terms of intensive care beds, which is where the sickest people tend to go. And again, probably about 1/3 of the occupancy at the Royal Stoke than we saw at the peak. Just in terms of vaccination, there's an item on the agenda later, so I won't steal Lynn's thunder. It's been a tremendous success. We are one of, if not the best performing system in the country in terms of vaccination rates. Lynn will run through the latest position in a moment. I just wanted to say thank you to everyone involved in the programme. 77% of our vaccines to date have been delivered by our GPs, practices working in primary care networks through local vaccination services. So that's groups of practices working together, pooling the resources to jab our patients. So 70% of those have been delivered by general practice, which is a huge achievement. So thank you for that. Also to our colleagues in hospitals who've done over 20,000 vaccinations, about 11% of the total. That's largely health and care staff. Thank you. Our pharmacies, about 8%. Again, thank you for them for providing additional capacity. And whilst our large-scale vaccination centres in Tunstall, in Stafford and in Orwas haven't been utilised to the extent that our local vaccination services and hospital hubs have been, with about 4% of the total. They will really come into their own as we start really ploughing through second jabs and vaccinating the wider population. So our response to the vaccination programme has been nothing short of miraculous. So thank you to Lynn, who's been the programme director, to Paddy Hannigan, Dr. Paddy Hannigan, who's been the clinical lead, to Neil Carr, who's Chief Executive Midlands Partnership Foundation Trust, who's been the SRO for the programme, for all of our colleagues across the CCGs and out in the wider system, to the volunteers who've helped to marshal and staff and guide our patients and citizens who've gone to get their vaccines. Having been vaccinated myself, it's a really, really smooth, slick process, a testament to the hard work that everyone's done in getting that stood up in such a short period of time. Something I think we should all collectively be really, really proud of. And most importantly, we are protecting the bulk of our most vulnerable population from a pretty invidious disease. Just finally, something around the merger programme. We did get the vote through, and we will be submitting a merger application for the 6 CCGs to merge. That will be being submitted by the end of March. We're expecting to attend a panel to assess our application on the 26th of April, and then at the moment we're anticipating to merge from the 1st of October. Huge amount of work to be done around that. So we'll need to dissolve 6 organisations and establish a new organisation, and then obviously in the second half of the year we will need to stand up a new integrated care system, which will comprise of an NHS organisation and a health and care partnership. So I think it's fair to say the next 12 months are going to be really busy in terms of continuing the vaccination programme in response to COVID, standing up services as part of a restoration and recovery drive, merging the CCGs, creating an integrated care system and integrated care partnerships. So huge amount of work to be done, and I think I'll probably pause at that point, Chair. Thank you.
Is there any questions? So, John, Peter, then Margie.
Yes, thank you, Marcus, for your report. Just like to ask you a question on the Strategic Commissioning Organisation and the extent to which, in your view, we will be able to build on what has been described as the COVID dividend of integrated and partnership working, and particularly in relation to local authorities and social care. I'm assuming you've got a pretty good high level of confidence that we're able to achieve true integration this time round.
Yeah, I mean, we've got some good examples, John, of where we have worked really well with our system partners and our local authorities. You know, the Better Care Fund, for instance, has been, I think, a really important vehicle in terms of how we join up commissioning across the NHS and local authorities around both adults and primarily adults services, but also some good examples of how we've actually brought together our children's commissioning, improved access to autism and other services, CAM services, and so on and so forth. I mean, the integrated care partnership is, you know, whilst there will be a partnership and a forum within which we work with our system partners, the proof's in the pudding. You know, how do we actually spend the Staffordshire and Stoke-on-Trent pound once, and how do we do that between us? So I wouldn't underestimate just how big a challenge that will be, but I think our experience through COVID, building on the work we've done pre-COVID, I think puts us in a good place. Relationships are much better than they were before. I think what COVID has really done is enable us to focus on, you know, what are the really important things we need to focus on, stop doing the things that may be less important and focus on the stuff that will make the biggest difference to our population's health and outcomes. And you know, one example being, for instance, the vaccination programme. So our response as a system, I think, to COVID has been really good, and there is a real willingness across all system partners to ensure that we lock in the benefits of that very integrated approach to what's been probably, certainly from my perspective, the most challenging period of my career, and certainly of most people's career.
A slight supplementary, if I may, please, Chair. I'm assuming integrated care partnerships truly extend to the voluntary sector as well. Yes,
I mean, the third sector involved in the ICS, they're involved in the sort of the integrated care system partnership board. They're also involved in the integrated care partnerships. And if you look at, say, one of our big issues, for instance, is around end of life care. So we do spend much of our money in the last year of life, most in the last 3 years of life. You know, we cannot actually improve the experience at end of life for our population if we don't work closely, for instance, with the hospice sector. Some good examples of how we work with the hospice sector, with the nursing home sector to really improve experience at the end of life. So some good examples of where we've worked with the third sector, certainly improved patient experience, improved outcomes. And given the very challenging financial position we've got, if we can get that bit of that sort of area of care right, it will also have a big impact on the number of people admitted to hospital and take pressure off our acute providers, and also probably enable us to probably spend less money. I think in the last year of life, people would expect to be admitted to hospital about 5 times. If we can reduce that so people are supported to die dignified death in their place of residence, at home or in a care home, that will have a big impact on the financial position of the system as well. So third sector really, really important, and we need to ensure they are fully engaged in our integrated care system going forward.
Thank you. Encouraging to hear. Thank you.
Peter?
Thanks, Chair, and thanks, Marcus. And I suppose continuing the theme, and you mentioned just the contribution that volunteers have made to the efficacy of the vaccination programme. I was helping at our local PCN vaccination centre this morning, and the extent to which local people are actively and very keenly involved in that is really encouraging. And I think we really ought to start to think about how do we capture that, and how can we use that within these new, more integrated arrangements that you're speaking around, because the community goodwill, unlike our budgets, is probably infinite. But it's just how do we lock that in, and how do we use it effectively? But I think, as you said, Marcus, as the vaccination programme has shown, if you do, we get some really fantastic outcomes. And I think there's a lot of appreciation, not just from the clinicians who are helped by it, but actually those people who have been involved, who appreciate the opportunity to help and in a national crisis. Thank you.
Yeah, and Chair, I would support that. As Peter said, the response from our communities in terms of volunteering, not just the vaccination programme, but the testing programme, giving up their evenings and weekends, has been humbling, really. And it is certainly something we need to build upon. There's a huge amount of goodwill towards the NHS. People really want to help. But, they do recognise the sacrifice many NHS staff are making at the front line, and they do want to play a part in that. So there's a whole range of opportunities, I think, where we can engage with people in terms of encouraging them to volunteer, and probably won't take a lot of encouragement. And I think that can make a real difference. So yeah, fully support what Peter said.
Okay, Margie.
Thank you. Margie Woodhead, lay member for patient public involvement at Stoke CCG. Thank you, Marcus. I build on what's been said before with John and Peter, so I won't go over those points. But I think it does bring me back to the community element of the restoration and recovery programme, capacity in the community, particularly the patients who perhaps are not occupying a hospital bed, but maybe occupying community beds in nursing home or other provision for rehab, etc., and bringing up the question of long COVID provision and support in the community, which is going to put an awful lot of strain potentially on community services. And also it's the long-term plan is around about moving resources into community provision even prior to the COVID pandemic. So I just wondered what your view was and what the status is in community capacity and capability, knowing that there's going to be increased sort of needs in the community, both physically and mentally, and possibly socially as well. So I just there's nothing in the report. I don't see it in the performance report. I don't know if it's going to be in the COVID update report. but there's very little detail around. It's very much acute based. If we're moving into a restoration recovery and things hopefully are improving, we need to be ensure that we can look after people in our community to the best quality and safety standards as required. So I wondered what your view was, please.
Yeah, I mean, I was asked at the recovery coordination group, which is works across Staffordshire and Stoke-on-Trent as part of the local resilience forum. I was asked to go and present on our support around long COVID, and Mikesh Singh, one of our GPs, and Professor Zafar Iqbal, who's Deputy Medical Director at Midlands Partnership Foundation Trust, accompanied me and gave I think a really good presentation on what we've put in place to support people with enduring after effects of COVID. It might be something at a future public governing body we ask Mikesh and Zafar maybe to present the work they've done. I think the feedback from national colleagues on the call was very impressive. It was actually quite a long way ahead of what we're seeing in most areas. So I think the work that we're doing in general practice with our community providers when people do leave hospital in terms of how we support them to get back on their feet and recover from COVID, I think is pretty impressive actually. And I think statistically around about as many as 1 in 10 people who get seriously ill with COVID will still have the after effects more than 6 months after they've been discharged from hospital, something like that. So a large number of people are going to be struggling for some time, and it is really important out of hospital in the community, we have the appropriate support in place for them. So yeah, a lot of work going on, and probably can't get into the detail now. I think Mikesh and Zaf will be better placed to do that. But I think you're right, Margie, maybe something that, given this is going to be with us for a long time, maybe something we present to governing body maybe in a month or two's time. Certainly be worth it. I've found it very interesting.
Yeah, and I think the public would find that very interesting and reassuring too. Thanks, Marcus. Thank you, and thank you, Chair.
Okay, Neil.
Thank you, Chair. Neil Chambers, Lay Member Governance for the South CCGs. Marcus, paragraph 4 regarding the mental health support for rough sleepers. Could you just give us a little bit more detail, or agree to promise to give us a little bit more detail in future on what that support will look like? Mm-hmm. Whether it will be integrated and holistic with, for example, social prescribers, the voluntary sector, housing, or is it specifically aimed at sort of medical and counselling support?
Yeah, no, thanks, Neil. I'm just wondering if I'm not sure if Wahid's on the call. I'm just wondering whether I could invite Wahid, who's been instrumental in securing the resource on mental health clinical director, whether Wahid just wants to maybe say a few words in response to Neil's question.
Thanks, Marcus. Thanks, Chair. I'm Dr. Wahid Abbasi, GP in North Staffordshire and Clinical Director for Mental Health for North Staffordshire and Stoke-on-Trent CCG, and Clinical Lead for STP. In terms of the mental health support for homeless people, the specific question around homeless, we have already commissioned a service through the GP Federation in North, which is providing a very valuable outreach service to homeless people. Not only just the mental health support, but we're also providing physical health support. And more recently, we have also provided vaccination outreach, vaccination clinics for homeless people. We have mental health resource available. We are working on the community transformation program, which is a 3 years, a massive program of community mental health transformation. And we hope that with this work, we will be able to expand this work across the whole Staffordshire. And I'm certainly more than happy to take any further question on this, and happy to have any discussion outside. But I feel very positive that I think this opportunity, the work we've done in North, in Stoke-on-Trent and North Staffordshire, will be able to replicate that work across the whole Staffordshire. Thanks, Chair.
Cheryl, did you want to come in on the same point?
Yeah, it was just to add to it, Gary. So I'm Cheryl Hardesty. I'm the Director of Commissioning Operations I just wanted to pick up, so Wahid's absolutely right, and this is a really excellent initiative for us. Just in terms of the social element and everything else, just to be clear, this was a funding from NHSEI and the Ministry of Housing and Communities and Local Government position, and so this was very much about a very joined up cross directorate, cross organisational and I suppose cross parliamentary areas, which is covering it all. It's essentially about Stoke-on-Trent, that because Stoke-on-Trent has been identified as in the top quartile, which is not good, even though it's top. But what we've agreed is that this is about how can we use this flexibly in terms of identifying key areas where we have some concerns or where we have small pockets of this, and we've been given some flexibility in order for how we use this funding, but it's brilliant and I think it will move on. So at the moment this is a first port of call for Stoke-on-Trent. We're linked very closely with the local authorities and the voluntary sector about this. I'm very happy to come back with something much more detailed, either to the next governing body or to whenever you like. I think it'd be helpful to keep this governing body cited on what this is going to do. It's very exciting.
Thanks, Cheryl. We'll take one last question from Jan and then we'll move on. Jan?
Yeah. Jan Toplis, I'm lay member for Cannock Chase CCG. I was interested in your report, Marcus, that you mentioned for our learning disability sites. Not all people with learning disabilities are necessarily in institutions. I'm not sure what you mean by learning disability sites. And could you tell us what the progress is in establishing vaccinations for that group? Additionally, Black and ethnic minority groups, I see that you've set up 2 pop-up clinics, but I wondered, have we any figures? Do we know how many people have yet to be vaccinated, and how are we setting about reassuring this community about the efficacy of the vaccination?
Certainly, Jan. I mean, Chair, would you mind if I maybe just ask Lynn to chip in with that? I know she'll cover it off in her report agenda item later, but yeah, good questions, Jan. And I didn't cover off how we're doing in terms of performance around the programme at the moment, so I didn't want to steal Lynn's thunder. But Lynn, do you want to pick those questions up, please?
Yes, of course. Thanks, Marcus. Thanks, Jan. Yeah, I will cover this later. I mean, we absolutely do monitor the figures down to a very granular level, Jan. And I can give you some headlines. So Marcus said we're very high performing in our, if I say mainstream population, but we did know that we have some inequity across certain groups. And that was something that we weren't happy with as a programme, and we've kind of adopted the mantra that we don't want anybody to get left behind. So we have an inclusion and equality group that Dr. Shami Moore is the clinical lead for, and we've seen some fantastic progress. So our rates for Bangladeshi communities were very low, for example, and we've done some different initiatives like pop-up clinics over the last couple of weeks to improve that figure. And I'd say we were probably average at the moment in terms of our regional position. Now, we were very low. We were one of the bottom 3 in our region. Now we're in the middle quarter and we're not stopping there. So week on week, I can see even in the last couple of weeks, we've seen an average of 10% improvement in uptake rates in those ethnicity groups that we're targeting. It may be that at a future governing body I can give the detail more and go through them in some detail. But again, in terms of learning disabilities, which is the other point, we've vaccinated 87% of our homes. We also know that people with learning disabilities live independently in other settings as well. Last week we were 77% of our LD patients have been vaccinated. This week we are, and just bear with me because I want to get this right. Yeah, so we were 77% last week. We're now 82%. And our ambition with all of our hard to reach groups is to ensure that they are receiving the same uptake levels as all of the other communities. So we don't want to have any inequity as part of the vaccine programme. Everybody's entitled to come forward to get their vaccine. We know that everybody's not going to get it in the same way. We need to do things differently. We're our clinicians, we've got best practice guides around learning disabilities. There are specialist clinics they can go to, and it takes a very personal approach to bring these people in, and we have to do things differently. So I'd happy pick this up in the later session, Marcus, but I can confirm that we do know the numbers and they are improving.
Thank you. Thank you. And Chair, if I could just, I mean, this is really important. I think in the first wave, around about 60% of people who died with COVID had a disability. So, yeah, really vulnerable section of the community. And as Lynn said, it's testament to the programme overall that we've actually got such high numbers of vaccines and the uptake so high in those groups. So, yeah, thanks for asking the question, Jan. It's an important one. Thank you.
Thank you.
Okay. As there's no further questions in any case, we need to move on. Thank you, Marcus, for your update. Month 11 finance report. Paul.
Thank you. I'm Paul Brown, Chief Financial Officer, and the last public governing body, which met in January, looked at the position for month 9, performance to the end of December. At that point, we were forecasting a break even for the year. Month 10, we moved that forecast to a surplus of 15 million. Which is actually 18.7 million better than the plan being a 3.7 million deficit. Pleased to say that month 11, which we're now looking at performance at the end of February, we've maintained that forecast and we're still forecasting a surplus of 15 million. I mean, three key reasons for that very positive performance. The first, just to put my thanks on record, Marcus did so, but mine too to the management team. It has required a lot of hard work in managing budgets, and that's been done very successfully. The second thing is that we, along with the rest of the NHS, have received additional money as a result of the COVID situation, and that's obviously played a big part. For us, a very significant part of that was funding through the hospital discharge funding programme, which resulted in the surplus position that we've seen. And then the final of the three areas really is that we've done a lot of work on the balance sheet. So a governing body may recall that we had some difficulty with our final accounts process last year that led to us to do a large amount of work looking at the balances on the balance sheet, and that's allowed us to improve the balance sheet, which has actually played through to improve the financial performance of the system. So that's all good news. The slightly less good news around the mental health investment standard, as previously reported for 2019-20, we previously reported that we thought we would miss that standard for some of our CCGs. We've now had an audit completed which has confirmed that. So we have actually met the standard in 2 CCGs, North Staffordshire, South East Staffs and Seasden. The other 4 we missed the standard. As the governing body may recall, a lot of this is down to technical reasons rather than what I would call real reasons in terms of the level of investment we made in mental health. We have actually made the investment at the level that we were required, and our providers have signed up to that too. So we will present that up the line to the centre. But unfortunately, in terms of the way the standard is constructed and measured, it is recorded as a miss for those 4 CCGs. However, in terms of 2021, again, as Marcus referred to, we are expecting now to achieve the standard in this year. It is quite tight. We've got a bit of headroom, but not a huge amount. But we are expecting to hit that unless there's some change to the target. And again, what we saw last year was some quite late changes to the target, and it's obviously very difficult to then hit a target if it changes. Assuming the target sticks at the level that it's currently at, we would expect to hit it. Final comment, in the papers we've set out our performance against all other targets, including the running cost target. You'll see in the paper that we are forecasting to achieve the running costs, which we are on course to do so, but as a result of the merger situation, there is possibility of need to accrue some redundancy costs in the year. If we did that, that could possibly mean that we missed the running cost target. So just wanted to alert the governing body of that possibility. I'll be able to report more next month when we have the month 12 figures. Thank you, Chair.
Thank you, Paul. Any questions for Peter?
Thanks, Chair, and thanks for the report, Paul. You mentioned that our positive financial performance was as a consequence of a number of factors. What was the proportion of the success down to the savings we achieved, and what was the proportion of additional money coming in that we hadn't perhaps expected?
Yeah, well, in our underlying position, Peter, as you know from the Finance and Performance Committee as a system, is a deficit of about 200 million, so quite significant. I mean, in terms of the surplus position, certainly the majority of the surplus itself, the 15 million, in fact, not majority, all of it comes from a gain on hospital discharge funding that we weren't expecting. So that is the drive that took us from break even into surplus. I mean, the benefits from the balance sheet work that I mentioned amount to about 5 million. The top ups quite difficult to answer that question, but our position last year in 2019-20 and will be going forward when it's based on when the funding is based on the funding population as opposed to the cost of the system are clearly quite different. So the top ups to the providers were a very significant factor that certainly closed the gap and was enabled us to have a chance of achieving break even. In terms of the QIP programme, as you previously measured, the QIP savings that we've declared in year are relatively small, about £10 million. So it's a relatively small part of the whole. So it's absolutely the case to say, Peter, the vast, the most significant reason as to why we're in a favourable position compared to last year is additional resources. There's no question on that. But it is also true to say that there has been a very good level of attention to detail from the management team on the budgets. In year again, as you know, through the work of the F&P, we've enhanced the level of delegation in preparation for the localities and the ICPs. And both the chair, well, the two chairs in each case of each division, along with the managing director, have really embraced that piece of work, and that is a factor. So it's quite hard to break down that into precise numbers for you, but I mean it is a significant factor and puts us in good stead going forward.
Chair, if I could perhaps just come back on that, and that's really useful clarification, Paul. So thanks for that. But I suppose and reason I raise the question is really so that we can highlight that that big financial challenge, that system deficit hasn't gone away, and it's going to take all of our efforts across that integrated system to get us to where we need to be in terms of balancing the books.
You're absolutely right, Peter, and it is a really important point that none of us are complacent and say, well, look, we've done it. We've made a start, I think, in terms of financial recovery, but you're quite right. There's an awful long way to go.
John.
Thank you, Gary. Thank you, Paul. Additional funding, whatever its source, is always nice to have, particularly if it culminates in a surplus of this magnitude, 15 million. But we are meeting in public, and members of the public perhaps would like to hear a little bit more about what you've called in your report additional schemes, because I know you and members of the executive have worked hard and consulted with external audit about ways in which some of this additional resource can be invested back into the health community. Could you, being as we are meeting in public, I think it's important that is shared.
Yes, thank you, John, for the chance to expand on that. Yes, so as John said, because we recognised going back since Christmas that we did have this opportunity really that we haven't had for many years in this locality, with the favourable financial position. We were keen to see if there were things that we could do that would help the economy, the local economy, help the health system, but also help the wider public environment to cope with the effects and to put in place things that would actually have a lasting benefit for our patients and our public. So we have actually secured agreements with the two local councils. In both cases, figures approaching 3 million of additional resources that we're putting through the Section 75 agreements we have with those two councils, with an earmarked list of programmes that we have agreed with those two, the two councils, Staffordshire County and Stoke-on-Trent City Council, for investments that I say will have benefit for residents and patients. That John is the largest element. There are some other specific ones, but you're quite right to ask that question so that the public can see that we have made that investment with our local council colleagues.
Thank you.
Tim.
Thanks, Gary, and thanks, Paul, for the report. I just want to pick up on the issue about the public perception around probably two key elements which are in the report. One, the mental health investment standard, and the other, the anticipated surplus in the financial position. Those of us involved in some of the many meetings that we've had to discuss our performance on the mental health and investment standard know how complex the issue is. But I think it's just important, given that from a public perspective, their only involvement might be just to see that we failed it, that we have a sort of duty and I suppose a responsibility to try and communicate that at every opportunity where we are making investments, and we know, the difference that we've made in a number of areas. So I just want to stress the importance really of getting those positive messages across, and particularly when we're now looking towards a year of major change in the local health economy. We will potentially, from a public perspective, be seen to be going from a position of surplus and back into an underlying deficit, and it's quite easy then to start pointing fingers at NHS restructures actually having the opposite of the desired effect. So it's just, I suppose, the public messaging aspect of this, and I think it's just important as we embark on this year of substantial change that we take every opportunity to demonstrate the practical investment that we're making in the mental health area, and B, just to get that message across about the underlying issues that we will continue to face in Staffordshire.
Yeah, I think that's a really important point, Tim. On the mental health point, what we need to do, what we can do, what we will do is bring back to the governing body the views of the providers, because we can demonstrate, with the providers that we have made the investment in services. And in fact, I mean, the irony is that we're actually one of the best providers of mental health services nationally in this system. So we actually have a very good track record in this area, and so it is a technical reason. It's very hard to explain. I won't. As you know, you've heard me try and explain it. It takes at least half an hour, and even then, I'm not sure everyone quite understands it. So I won't try and do that right now. But what we can do is bring back to this governing body some information from the provider side, which will hopefully demonstrate that what I said is the case, which is that we have actually made investments in mental health that our population requires and that the standard expects us to achieve. The wider point about the, and it's building on Peter's point, isn't it, in terms of we had a big deficit last year. This year we've got a surplus. Next year we've got some challenges again. It's very hard to see the pattern of that and to make sense of it. I think one of the things that has been good about the kind of the suspension of some parts of the financial regime over the past year is that we have actually been able to spend quite a lot of time working on how we deliver the savings as a system, and we haven't had a great track record of the last 10 years of doing that. But I do feel very optimistic that the work we've done and the groundwork we've done will mean that we are much more able as a system to come together and deliver the improvements in a way that will be beneficial to our patients. And again, it's might sound a bit theoretical, but in my view is absolutely the case. Those health systems that have the best quality of healthcare actually have the best finances too. They go hand in hand. And what we've been able to do is think about ways of delivering changes that are driven by the clinicians that achieve the best pathway for patients, and then on the back of that, delivering the financial improvements. And that type of approach and program takes a lot of time, and we need some more time. And we have made progress. We need some more time, but I think we're on a trajectory where we can actually deliver it in that way, and that's obviously the prize. The prize was to make our health services better and to live within our money.
Appreciate that. Thank you.
Okay, so there's no further questions, I'd like to move on. For the minutes and the public, finance is subject to scrutiny of the Finance and Performance Committee. So although we've only spent 10 minutes on this, it is given far more detailed discussion at that committee.
Yes,
thank you, Paul. Yeah, I'm glad I'm not doff sometimes.
I think you may have introduced me, Gary, did you?
I thought I'd taken off mute. I don't know what's going on. Blinking
That's
team.
absolutely fine. Lynn Tolley, then Deputy Director of Nursing and Quality for the CCGs. Draw your attention, I'll take the paper as read obviously, just draw your attention to page 2. We approved in Quality and Safety Committee 5 items, and we need them ratifying today in governing body. The first was the research funding for staffs. This is where the CCG pool research capability funding via Keel, and they're into their second year staffs, and they have to progress to a certain criteria of which they have succeeded. So we agreed that. The second one was special educational needs, the SEND strategy for Staffordshire that runs from 21 to 26. And that again is going through the local authority and the CCG governance processes. It was a co-produced document with parents and children as well, and that was approved. Safeguarding policies, they had minor amendments to them because the boards are split into 2, so just a slight governance amendments were made in those policies. And then the last one was by virtual approval, and that was again research capability funding across Staffordshire, which again was agreed, that was by virtual and approved by the QSCC members. Are there any questions, and are the governing body happy to ratify those? I can't see any hands up, Gary.
I can't either, although it appears there's a few problems with hands. Just to say, if you do put your hand up and you don't get called, can you shout, please? Because we have had a few problems the last couple of days with them, both showing when they shouldn't be and not showing when they should be. For the minutes, asked to ratify the decisions with regard to research funding for staffs, SEND strategy for Staffordshire 21 to 26 and 2 safeguarding policy approvals. And ratify decision regarding the research capability funding for Staffordshire and Stoke-on-Trent. So Lynn, which Lynn? Must be Lynn Miller. So have Lynn Miller and Neil Chambers got their hands up?
I can't see them.
No, not me.
There may be legacy hands. Do you have to carry on, Gary?
Frankly, I can't see any up. So those are the 2 decisions, or the 4 decisions we've been asked to ratify today. I'll take silence as assent.
Yep.
Happy to approve to ratify. Thank you.
Okay, I'll move on then. So in the paper, I'd just like to highlight a few points. First of all, the John Munro Group, you will have noticed they've had it's an independent mental health hospital. It has 60 patients within it. They had an outbreak over a period of 3 months, starting in early December. The local authority public health director commenced weekly outbreak meetings, and an improvement plan was developed and monitored and very closely by the CCG and local authority. CQC, all our partners were involved in that. CQC, Public Health England, Local Authority, IPC, Specialists, NHS England, etc. A risk review took place on the 4th of February. That was chaired by the Exec Director of Nursing and Quality. And from that, we decided that there's a continuation of weekly quality improvement plan meetings. In addition, there's weekly IPC meetings with the provider, so that's 2 meetings per week to support this provider. We are seeing improvements within the provider. The last case was the 16th of February. We have, those of you who know how the testing works in the community, care homes can register nationally, independent hospitals can't register. So locally, we've had to provide a solution, and thank you very much for UH&M. and the practices that are with these providers, because they're supporting the providers with PCR tests, so they can do their patients on within 28 days, each 28 days. So that's working really, really well. Vaccination to date, we have 52 of the 60 patients and 149 of the staff vaccinated. So we're in quite a good place with John Monroe Hospital. Of the individuals, the patients that died during that period, we are awaiting the full RCAs. We're not expecting any new learning from that, nor are we expecting any new learning from the CQC that visited the establishment in December and January. Any questions on that before I move on, or do you want to wait to the end? Wait to the end? Okay. Just on UH&M, you will see that the falls have risen to seven falls per 100,000. Now, they're usually at 5.6. This is because they're not seeing the patients close doors because of infection prevention control, donning and doffing, taking off the IPC and back on their equipment. But that's nationally, that's not just at UH&M, but they are putting interventions in place to support and hopefully prevent falls. Rowley Hall Hospital, you'll notice there's a never event, wrong site injection. There has been 2 never events previously in 2020. One was the wrong site injection and the other was wrong patient. So that's been looked at very carefully regarding who's involved with that. So the RCA, we'll wait for the outcome of the RCA. You will notice that the Thomas Oliver McGowan recommendations, this was a young man from the Learning from Disabilities Mortality Review Programme. And there were 21 recommendations, of which 11 the CCG have to report against. And I'm pleased to say that all of those recommendations, we're making progress against them even before the recommendations came out. And then just to pick out D2A monitoring, as you'll see in the paper, we're going to strengthen the quality assurance processes with the monitoring, just to triangulate the information we collect on D2A. And I'm happy for any questions.
Any questions for Lynn? There's the report. Peter?
Thanks, Chair, and thanks, Lynn. And it's on page 5 of your report. I think it's page 90 in the electronic bundle, where it's talking about waiting list monitoring. Because as we've seen, waiting lists, 52-week waits are going up quite significantly, and as a result of the response to COVID. But I'm just wondering, what are the sort of mitigations that are being put into place? So what things are happening for patients, if they are seeing deterioration in their conditions, and also what are the thresholds for people actually getting the treatment that they're waiting for? So is it to avoid them dying, or is it to avoid sort of continuous severe pain and that sort of thing? So what are the things that are going to determine whether someone is given the treatment, or that they still have to wait? Thank you.
Okay, thank you for that, Peter. All the waiting lists are clinical prioritisation, so they work through the list and look for clinical prioritisation. We have communication to GPs, so if patients turn up at GPs, they have an hotline specifically for UH&M. Wellbeing checks, patients tracking list management. There is a lot of initiatives going into those waiting lists to see whether there's any trigger points. And I don't know whether Steve wants to come in here specifically about UH&M at all.
I mean, I haven't got any. Which elements did you want me to cover off, Lynn?
Oh, the bits with UH&M, specifically for UH&M, about the clinical prioritisation of the waiting list. Yeah.
So, I mean, the prioritisation actually is similar to what's happening in trusts across the country. It's nationally defined, and the way that they're managing it it makes a great deal of sense. And what they're clearly doing is making sure that people with the most urgent needs are getting dealt with in an appropriate time frame. The bit that will be the problem, I suspect, is when you get into the priorities 3, 4 and beyond, because although those will have a number of months attached to them, the way that the waiting lists are waiting, and looking at the 52-week lists growing, some of those will wait longer. So they're working through a process about how do you continuously review those patients who are waiting longer than their allotted time span. And some of that's being done through desktop review. Some of that's being done actually through structured communication with patients, so that they can self-refer, if you like, if there are issues that are deteriorating. Does that make sense?
Yeah, I was going to pick up on Steve that they've got a direct line number, haven't they, to UHM patients and GPs?
There is, and there's also what they've set up is on the what's called the Consultant Connect platform. They've set up a specific identified resource so that if you have a query, you can fire it in, and UHM will respond directly. So they are being quite proactive about managing it, because they realise there is a challenge.
Yeah.
Thanks, Steve. Thanks, Lynn.
Thank you, Peter.
I think just on that topic, and actually we're moving on to the performance report, really sort of a crossover between quality and performance, isn't it? On that, certainly RWT, Wolverhampton Trust, who serve the majority of our South population, they have a similar mechanism in place.
Yes, they do.
Whereby the patients can contact, or are given a number to contact if they need to. So just to assure the public that it's not just UHM, but other trusts where our patients go have also got similar mechanisms.
And just to note that the Royal College of Surgeon guidance for clinical prioritisation is being followed by all of our providers as well.
Thank you, Lynn. In which case, I'm now going to move on to the performance report. Jane?
Thank you. So I'm again going to take the report as read. So what I want to do is just highlight what some of this data is telling us about some of the things we're going to need to think about as we move into recovery, and some of the issues it raises about making sure we do this in a way that's equitable and doesn't increase health inequalities. So I'll start with the picturing urgent care. So what we have seen over the course of this year is really a reduction in A&E attendances. Now, some of that is probably associated with, particularly in the periods of lockdown, with people not having some of the major trauma, such as road traffic accidents. Some of this is probably because there's been a lot of work put through things like Think 111 and the use of places like the Haywood and other centres to divert some of from A&E. And some is probably a change in behaviours, some of which we'd probably like to maintain, because we knew that before COVID, from some of the clinical audits and other things, that there was a significant percentage of people who were attending A&E who really didn't need to being A&E. So there's some learning that we need to take from that. And even now, as the cases have come down, activity and attendances is still below the level it was pre-COVID, and it's the lessons about we want to take from that I think is really important. And that's also reflected in terms of also admissions for urgent care. Again, some of that's down to people not having some of the accidents, etc., that they did. Some of this is probably the work that people have done around diverting particularly the frail from the front end and keeping people out of hospital. And again, it's about how do we capture some of this learning and what we might want to build on going forward, which is going to improve the outcomes for patients. In terms of where we are in terms of cancer, I think cancer is a really good news, and it links to the earlier question under quality about making sure that we are recognising where it is important that people have been treated across the board. And I'm going to do this with a proviso that University Hospitals of Birmingham has really been struggling. Our cancer pathways have been maintained, and in fact activity has been maintained at rates comparable to that. In fact, in some of our providers it has actually has improved compared to pre-COVID, and the level of people who are going through those pathways from both GPs and other routes, and the number of people treated is up to about the 90% of pre-COVID. But that still means that we have seen a reduction in the number of people who are coming forward and are being put onto those cancer referral pathways. So, and this will be a recurrent theme, that we are going to have a real challenge about unmet need that may well be coming forward over the next few months, and about recognising that that is going to be an issue for us. And probably the final area I just want to highlight is we just said in the quality in other sections about elective care, so planned care. What we have seen overall is that the waiting lists have not overall grown since this time last year. What we have seen is an increase in the length of time that people are waiting overall, and particularly an increase in the number of people waiting over 40 weeks. So I think at the beginning of COVID, there was some concern that there'd be a major increase overall in the waiting list. That doesn't seem to have been happening. Some of that may be, as we've reported in the report, that outpatient, our acute trusts, all of them have maintained their outpatient pathway. So those who have not needed further treatment have been seen and dealt with. Some of this again has to be of concern. Have we got a group of people who haven't sought treatment? We know from the national position that certainly there's been a change in behaviour, in particular on some of our more vulnerable groups around seeking treatment. And that's we will need to be looking at in more detail as we go forward. And we have got this increasing issue of people who are waiting a very long time. It is right that we are recovering on the basis of the urgency and the need for treating, but this does have the potential for certain categories of patients and certain groups not to be seen as quickly as we go through recovery. So really that was all I wanted to say, just to highlight those, and that as a system we've already started some of those discussions about recovery, and that has included recovery across community and mental health, and the implications of some of these changes on all of those areas as well. Thank you, Chair.
Thank you, Jane. Any questions for Jane? Peter?
Yeah, thanks, Chair, and thanks, Jane. Sorry, I'm just a bit confused around. You said overall the waiting lists haven't increased, so that's in terms of the number of people.
The number of people waiting hasn't increased overall,
but because the capacity to treat them has reduced, the length of time they're waiting is longer. It has a big implication. So even with that waiting list, we probably, the figure at the moment is that the NHS expects that there will be a 10% reduction in productivity just because of we'll need to maintain COVID. So just getting through that is going to take longer. What we've probably also got is that we've got some unmet demand, people who haven't come forward for treatment. So all it's doing is highlighting that there is probably more of a challenge around recovery than it would look like if you just took the overall waiting list. Okay, thanks for that.
Thank you, Jane. For the performance report. We're going to have a little jig around now. So rather than move papers around, I'm going to move sections around, like I said earlier. So the next bit I'm going to do is items for ratification. So the first one is recommendations from APC, which is down for Amin to do, who's not on the call. Lynn, is he here today? Lynn Miller. Okay, I guess you're on mute, Lynn.
Gary, would you like me to do mine while you're waiting?
Yes. Which one's that? Oh, the new vaccine incident reporting process. Yes, please.
Okay, this is the incident reporting process that we've put in place for vaccination sites to make sure. So if there's an incident on site, this shows you the flow of where the information will go and how the governance is within it. And I'll take the paper as read, but I'll take any questions if people want to ask any questions. I can't see any hands up, Gary.
Apart from yours, no. Any questions for Lynn? No. So we're being asked to ratify this process, and presumably we're happy to do so. There's no questions. I'll take silence as assent.
Thank you very much, Gary.
Thank you, Lynn. Paul, do you want to do your recommendations from the F&P?
Yeah, it's actually fairly straightforward in that the main two items where there were recommendations. One is going to the private meeting of the governing body later on IUC for consideration there before coming to the public governing body. So that doesn't need ratification here. And the second was the budget paper, which does require approval, but is on the agenda separately. The other matters were all for information.
Thank you, Paul. So essentially nothing to ratify. Is Neil?
Just a point for the minutes, please, Gary, just to confirm the point you made earlier. The performance is also dealt with in much more detail at the Finance and Performance Committee, as opposed to in significant detail at this meeting. So it did receive appropriate scrutiny and questioning at Finance and Performance Committee.
Absolutely. Okay, is Lynn? So if Amin's not here, would Lynn or John like to present the APC recommendations? Lynn?
Yeah, sorry about that, Chair. I've been having a few problems with my internet. I had to shut down and come back on again. Just to say, the paper you've got in front of you is for ratification of a number of drugs that I won't attempt to pronounce. And as you can see, they are red rated drugs, both NHS England commissioned and CCG commissioned. Just for clarity, you may ask, why is one grey? It's the one beginning with M. Why is that grey for North Staffordshire and red for South Staffordshire? The reason for that is it's NHS England commissions, and it relates to the tertiary centre, of which North Staffordshire is not one of them, so it's not applicable. So the paper's there for ratification.
Thank you. For North Staffs and Stoke-on-Trent committee members, are you happy to ratify that paper? I'll take silence as assent as usual. All those drugs, Lynn, that you can't pronounce, there is actually a proper naming mechanism about how they get their names. Saddos like me quite like that kind of thing, so
as you can pronounce Manila,
still can't pronounce them, but at least I know why they're called what they are.
It's what Amin's for.
Correct. Okay, so that's the items for ratification. We'll move on to the items for information and the reports from the committees. So attached to the papers is the moderate hearing loss for North Staffordshire CCG, which is there for information only, not for discussion. Jane, I don't know if you want to say a little bit about COVID-19 update at this stage.
I can. I will keep it brief, Chair, because I know we've got a lot to get through. So just to reiterate the position that Mark has said, what we are seeing is a plateauing of the case rate, and for Staffordshire and Stoke that remains above both the West Midlands and the England average. The reason for this plateauing seems to be that, in fact, the Kent variant, I don't know whether we should call it the variant anymore, because it's the predominant strain of the virus that is now circulating across both the UK, and as you've seen from the third wave of COVID that's engulfing Europe, is rapidly spreading across Europe. And what seems to be is that the increased transmissibility of that means even with the sort of lockdown, we're still seeing a ongoing community transmission, which is mainly in the working age population. So that is a significant proportion of the adult population that hasn't yet been vaccinated. The good news is that when you look at that against what's happening in terms of hospitalisation and particularly critical care, we've seen a dramatic fall in both the number of beds occupied by COVID and particularly critical care. Now, we've done some additional work with our acute trust using some of their data. What we can show is that that fall in terms of hospitalisation and critical care occupancy is most significant in the over 80 population, which has now had been vaccinated long enough ago to be that benefit to be able to be said to be clearly linked to the fact that that age group had been vaccinated. So we're demonstrating within the system, as they are nationally, the benefits of that of the vaccine in terms of preventing severe illness in the population. Overall, we've been doing some work with our colleagues around outbreaks, looking particularly at care at home outbreaks. It does highlight that we are still, even with the first dose of the vaccine, we are still seeing some cases that are happening. Some of that's because even with very effective vaccines, they're not completely vaccinated. Some is because we do have people who for various reasons weren't vaccinated. But I'm being asked, particularly from PHE and public health colleagues, just to emphasise the need that what they are seeing nationally is change of behaviours, where people have had the vaccine and think therefore they're protected from everything and are not observing social distancing, masks, and people will still continue to get COVID. And it's really important we get those messages out, particularly for the most vulnerable, about needing to maintain these requirements. So that's really all I was going to say, Gary, for the COVID update. There's a lot more in the paper and I'm happy to take questions on it.
Any questions? Apart from people from Kent don't like it known as the Kent variant, but there you go.
They don't. But the rest of Europe calls it the UK variant, so that's probably even worse for us.
Okay, thank you, Jane, for that. Unless there's any questions on that, we'll move on to the updates and the subcommittee chairs at this stage. So quality, is that Jan? Top, please.
Hi. I think Lynn Tolley's rather stolen my thunder. So everything I've prepared, she's talked about.
Sorry, dear.
Sorry?
I said sorry.
I think it's important to point out that the meetings have been rather shorter than were in the past prior to COVID. We're about now to return to fuller meetings, which will commence in April, where we will scrutinise information. It's really been prioritisation of tasks. So I think the Quality Committee will be returning, or Quality and Safety will be returning to its normal operation as of April, and Paul will resume chairing of the meeting from there on in. So that's all I can report, really.
Thank you, Jan. That's fine. Any questions? Just put your hand up for these items and I'll call you in. Anne Heckles, Key Committee.
Thanks, Gary. Anne Heckles, lay member for South East Staffs and Seaton, CCG, and East Staffs, CCG, and chair of Key Committee. I'm actually taking the paper as read, so I'm happy to take any questions. The only thing I actually wanted to say over and above what's in the paper is, again, similar to as Jan said, we did reduce the length of the meetings over the last few months to support people's workload commitments around COVID. But we gradually have started ramping up the meetings again, and we're now almost back to full meetings and full time, particularly as there is so much going to be happening over the coming months in relation to work of the committee. So I'm happy to take any questions.
Any questions for Anne? Nope.
Okay.
Thank you, Anne. John, Audit Committee.
Yes, thanks, Gary. John Howard, lay member governance, Stoke-on-Trent CCG, and chair of the Audit Committee in Common. Just 3 or 4 points, if I may, Gary. We met only last Tuesday, the 16th of March. So the 3 or 4 points are: we continue to receive very positive reports from internal audit that provide assurance on the work they are undertaking. We've received some further assurance on some issues that gave us cause for concern around continuing healthcare and personal health budgets, and some investigative work is ongoing there. But I'm pleased to report to governing body that the draft head of internal audit opinion is better than last year. It's more positive, and although it's in draft form, I'm confident that we will be in a better position in terms of how that's reported in our annual governance statement. We also had an input from external audit. We reviewed the plan for the year-end audit and the production of the final accounts, and all seems to be going reasonably smoothly there. And we also received from internal audit the draft internal audit plan, which was given some consideration, but also prompted us to set up with internal audit a workshop earlier this week that did lead to some modification of the plan to recognise the 2.5 years leading up to a merged single CCG. And the next stage of that process is to involve the chairs. So I think an invite will be going out shortly to all the chairs to try and get them to meet with internal audit to make a contribution in that respect. And then a couple of final points. Governing body will be aware that last year, or was it earlier this year? I think it was last year, we brought to governing body an action plan that addressed some of the concerns about we had, if you want, with internal and external audit in the previous cycle. And I'm pleased to report to governing body that we are maintaining a very good level of progress against the actions that clearly demonstrate improved relationships and improved responsiveness in terms of working closely and in partnership with internal and external audit. And the final point, Chairman, is to confirm that the Audit Committee in Common will be taking on an important role to provide oversight and scrutiny on the merger process. And as a result, we will now be meeting monthly up to October 2021. So if there are any questions, I'm happy to take them, Gary.
Any questions for John? Thank you, John.
Thank you.
Neil, this should be very short. Remcom.
Neil Chambers, line member governance for South CCGs and Remcom chair. There has been no remuneration committee meeting. Thank you, Chair.
We won't have any questions as to why there hasn't been one, but it hasn't been needed yet. So, Sally, can I ask you to do the rapid decision-making process?
Gary, sorry, just before you move on.
Yep.
We do expect, of course, no, we don't expect. We will be the committee when we make new appointments that will look at that process and look at the remuneration for the new accountable officer and other senior colleagues.
Yep, absolutely.
We will be informed of that in due course, as will governing body.
And there'll be a piece of work around objectives for those people as well. So, Sally.
Right, nothing to report, no new rapid actions to go through, so that's very short for you, Gary.
Thank you, Sally. Right, that now brings us back to the matters for approval, discussion and assurance. Jane, do you want to start with your 2 papers on health inequalities and then population health management, please?
Okay, thank you very much. So again, I'm going to take the report, and we've also included a slide pack with more detail So I want to highlight probably three things. One, that this is a very collaborative approach across all the partners in our health and care system, all the provider organisations, local authorities and our community voluntary sector. It's very much built on needing to take the learning and understanding from what has happened around COVID and really look at inequalities through that lens about how we, as we go forward into recovery and further forward, we actually recognise the real inequalities in our communities, deprivation, ethnicity, etc. We are building it on a strand where we need to make sure that is built on a real understanding of that population and the risks within that population. So we're using a population health management approach. It is about making sure that as we recover from COVID, we build in a much stronger emphasis around recovery that addresses and does not increase inequalities. And certainly the learning that has come out both locally and from nationally from things like the CMO's working group and from PHE is that understanding of the perspective of our communities about why they engage and do not engage with health services and other services. So all of those will be taken into account. We're also working so that this programme links with the wider inequalities programmes that our local authorities are leading on, that recognises some of those wider determinants of health and the need not only to address these health issues, but the learning we've also had from things like COVID on things like the importance of housing, insecure work, etc. So the aim is that this will be part of a sort of concerted approach to trying to reduce inequalities within the population of Staffordshire and Stoke-on-Trent. So that's the sort of introduction, and happy to take questions, Gary.
Thank you, Jane. Tim?
Yeah, thanks, Gary, and thanks, Jane, for the presentation. You touched at the end then on the work with the local authorities. Public health budgets have suffered some cutbacks in recent years as obviously local authorities have had to address funding issues. Really pleased to see the focus on prevention in the report. I suppose it's just seeking assurance around the likelihood for investment in this area going forward. It is critical if we're going to make longer term changes in both the health of people and in tackling health inequalities, but it's just that sort of backdrop of recent reductions in resources that concerns me.
And I think that's going to be an ongoing issue, but I think our local authorities recognise the real importance of inequality. Certainly Stoke has over the course of the COVID made some really significant investment around community champions, etc., recognising that need to actually have people who are working and part of those communities to support this agenda. I think there's a recognition that we've all got to step up on the prevention, so not just the local authorities, but there is a significant and there's a lot of work that's been happening at the regional level across the NHS on this, which recognises the need for the NHS to make sure it's got the right focus on its contribution to prevention as well. So as I said, I think this very much has to be seen as a sort of connected, and that we all use our resources most effectively. And some of this is not about new resources, but making sure we target those resources effectively to address those who've got the most significant need or ability to benefit.
And if I could just have a very quick follow-up. Will we also have a sort of commonality in terms of the sort of joint needs assessment that we've had previously? Because from my perspective, we haven't always potentially had a common view of how we address that. So is this new approach likely to bring about that benefit? So that's part of that. So we need to make sure that we're using jointly that joint needs assessment, and it's why you'll see in the inequalities that we have said that this is not just about how it goes through the sort of NHS and the ICS board. It needs to be joined up with the health and wellbeing boards as well. And yes, certainly
part of our conversation is all about how we make sure that we are using a common view of need. And that's why we've joined up in terms of the intelligence cell. That is jointly between our local authority and NHS partners. And in fact, a lot of the epidemic contribution to that is coming from the expertise that we've got from public health colleagues and other local authority analytical colleagues.
Thank you.
Peter?
Thanks, Gary, and thanks, Jane. And I have to admit to a degree of frustration because a lot of this information has been presented in other fora in the past, whether it be local strategic partnerships to, as you mentioned, the health and wellbeing boards. And so my question is, so why is it and how is it going to be different this time in terms of the impact of these activities than it's been in the past?
So I would just say that COVID has shone a spotlight on the real impact and the consequences of that, and those real-time consequences for not addressing inequalities properly. So I think we have a real opportunity to build on that now, and we need to grab that and actually recognise those deficiencies. And I don't disagree with you about a lot of these we knew about. I think there is a much stronger focus. There is a lot of work that's been done at all levels now in the NHS to make sure we can support and address some of these inequalities questions. And I think there is a recognition that to fail to do so has longer term consequences that are significant, both in terms of NHS and its ability to provide sustainable healthcare, but across the whole of society. And health is only one contribution, which is why I wanted to highlight this isn't just a question about us working in isolation. It's about the contribution health brings to that overall need to improve and reduce inequalities.
Okay, thank you.
Steve?
Yeah, Jane, it's really helpful to see this laid out. The bit for me, I suppose, being a clinician, is trying to understand the sort of so what bit.
Mm-hmm.
So we'll do a lot to describe what the problem is, but I think I would find it helpful to understand where we're going to actually intervene. What are the interventions? What are our plans to start testing out what we can do to help our population?
So I think that's what we're doing now. We're starting from some of the basics about what might be some of the long-term consequences of COVID. So we're doing some of that population health management data. So we're starting to look at what's happened in terms of age, deprivation. We're trying to start and working with our colleagues about ethnicity, but that's more challenging because recording of ethnicity is more varied. It's already highlighting some interesting facts that we need to think about in terms of recovery and what we may see in terms of long-term health problems coming out of COVID. I do think as part of the building of pathways and the prioritisation, we need to build this in. We need to build inequalities as a key criteria when we're thinking about the outcomes we expect from projects. I also think that in practical terms, I think it's one of the things we are going to have to look at as we recover. We've talked a lot about clinical priority. What we will need to make sure is that when we're looking at this in the longer term and the broader view of a waiting list, that we're not inadvertently affecting some populations more than others in terms of what that means in terms of that recovery of waiting lists. So those, Steve, for me would be the sort of first set of sort of very practical things that we need to look at in terms of inequalities.
Yeah, I don't want to press really, but what you're describing is again is examining what the status is. I suppose I'm really interested in how we're going to translate that into interventions, because we can describe the problems. I think you're describing them really well, but I'd want to see how that translates into practical, changing a pathway, changing resource allocation, and so forth. And I suppose I'm just thinking in my own mind about what the timeline is for those sort of things to happen, because I think most clinicians are, and I think you're right about the COVID, but I think we've had broader issues around long-term conditions, different outcomes across the patch, and it's about trying to see the so what, if you like. So that for me would be the bit I would look to try and understand. You may not have an answer for that now, but I think that's definitely what we need.
And I don't think it should just be an answer from me, Stephen, and I think it's got to be heavily clinically driven. So what I'm pleased about is that the Clinical Senate, for example, has made it a key priority that health inequalities needs to be one of the key areas. I think it's certainly something that I would expect clinicians to be heavily arguing for as part of the development of pathways that we are really focusing on inequalities. But I think part of this has to be a sort of clear sense of where we think we need to, we are going to have the most opportunities to improve outcomes and reduce inequalities. Now, that's got to be a collective view and not just, and that's why we are, as part of this, there will be a clinical focus with a clinical chair and a clinical led group, which is really starting to pull some of the key actions that we might want the NHS to be taking, starting with understanding where we are, but actually rapidly moving on to challenging some of the questions about what are some of the key things that we need to build in, both to our sort of recovery, but I would also say into, as we move into the sort of new ICS ICP, what we need to be building in from a clinical perspective into to the sort of areas that those the system and the ICPs are focusing on. But that's not an answering, because I don't think I've got oh, I should provide that answer. It needs to come collectively and be clinically led.
Thank you, Steve. Diana? Unless, Shami, you got your hand up. Did you want to say something about inequalities? Or was it a separate question?
Yes, please. Yeah, just to say, I mean, going back to Steve's point, when you tackle real problems, then you sort of develop a real sort of strategy. So if you look at the vaccination programme, you know, we saw massive inequalities 6 weeks ago, and within a period of time we've put in place loads of actions and made a huge difference working with partners and things. So I think the vaccine programme probably can teach a lot about how to address some of the inequalities, you know, making it the so what, making the practical difference rather than talking about the problem.
Yeah. And I think it has to be built on the practical things we want to do as a system, and we have to build inequalities into that. That's just what I was trying to say. It needs to be owned rather than coming up with a sort of wish list of things.
Diana?
Okay, I think you're right that this is a real opportunity for real changes to take place on this. It's obviously difficult because neither the NHS or the LAs are going to have any cash to throw around on this. I'm very much aware of the creativity that exists within the community amongst a lot of younger people who have nothing to do with health, but would contribute to the better functioning of the communities, which in terms builds health. I'm just wondering how far down you're going in order to determine what the needs are within the communities. I mean, is it us leading the conversation on what the needs are, or are we really asking people to define this?
So that's why we're working with our local authorities and their community ambassadors and things, because certainly one of the key learnings from COVID has been that that we have not always understood very well from a community perspective what the issues are, both about their accessing of healthcare, the and also their perceptions of healthcare. So we need to understand some of that so that we're getting some of that bottom up approach.
Thank you, Margie.
Thank you. Yeah.
Thank you. Mine was on a similar line to Diana's actually, and it is about the infinite sort of ingenuity of communities to come together when around problems, and I think we don't tap that enough, and that came very evidently through particularly the first waves of COVID, where communities harmonised to give the support that was needed to support their community. I'm glad to see the JSNA resurrected again, because it's had, it used to be something that we based our commissioning on in early days around the links between the JSNA and our strategic direction and commissioning pathway. So that's good to see that harmonisation with the Health and Wellbeing Board brought into this type of arena. But the area that there were two areas I wanted to really question in the paperwork. I felt that we're missing an opportunity. If we go to page 8 of the actual presentation report, which is community preventive programmes, I think that section is all the way through, I think, a little bit weak. And I think building on the strength that we've learned from community harmonisation through COVID, we could actually be a little bit more creative on that, particularly with our the ICP element of the work and the local area place-based working. I think there's so much more potential there than just doing, introducing social distancing and hand hygiene. Whilst they're really important through a pandemic, there's so much more we can learn from that going forward as well. So I think there's a bit more work that can be put into that element of the programme, and that goes into the community project. And then it's the time frame as well, where we on the last page, which is page 16, we have a time frame that we've already gone past in terms of implementation, which brings in some of Steve's questioning about the so what and when and how will this impact. And I think it's that strategic oversight group, who exactly is on that and where is that in the order of things? Is that at an IHCS level? Is that going to be disseminated to ICP level? Is that going to be further disseminated to primary care networks? So I'm a little bit sort of wanting a little bit more detail as to the what and how, because the rhetoric is great, but the rhetoric's been around for quite some time, particularly in Stoke-on-Trent. So I'd like to see the actual impact of the rhetoric.
So the reason for those projects is that's the starting point. Those are some of the things that we're starting on with working with the communities. Recognise that, but I think there's a really key, and this is highlighted heavily by our colleagues from local authority and community, is the need to work with communities on the issues that they think are most important. So we're taking some of the learning from the work that Stoke's done on community asset approaches, and we'll be building on that. So some of this is not trying, Margie, to predetermine, but work with our communities on what would be some of those issues. And whilst recognising there are other ones where we actually need to engage actively with communities, such as on the vaccination programme, about how best do we work with them to support people to be positive about being vaccinated. In terms of the timeline, all those strands are underway. So we have asked all our acute providers for clinical inequality champions, and we're starting. And as the recovery work starts, we'll be trying to make sure that we are incorporating the sort of work with those clinical champions around building on that. We have already started work with the local authorities and the community around the community projects. So it's slow progress. We got slightly delayed because of what happened over December and January in terms of this sort of increase in COVID. But there is work going on all of those elements that are in that timeline. Margie.
Thanks, Jane. I just wanted reassurance where we were in the development. Thank you.
Lynn, take this last question, then we need to move on.
Thanks. It's just to support, really. I mean, the vaccine programme's been mentioned, and actually the vaccine programme could be a case study in inequality. So the volumes are important, but actually we knew that we weren't successful unless we took everybody with us and everybody was vaccinated. And there are certain key groups that we had low uptake rates, and we weren't happy at that. So it was some of our BAME communities, but it was other people in deprived areas. Obesity was a factor, learning disabilities, severe mental illness, homelessness, and in all of those and some chronic conditions as well. And there is individuals scattered across the county. They are small and they're difficult to find, but once you put them into subgroups, you can see that there's a large number of people that weren't accessing the programme, and the likelihood is across every pathway it will be the same groups of people that are not receiving the same level of service. And I suppose for me, the learning I've had in the last sort of 6 weeks and working with Shami is that one size does not fit all. When dealing with inequality, it's not something separate. It's not something that the local authority deals with. It's something that collectively we have to tackle in each area of work that we look at, and it takes focus and it takes effort. And you have to do things differently. You have to go into that granular detail. So I think they are the kind of practical questions that and different solutions that we need to take forward as part of every programme of work that we do.
And I think I can only second that. And just to say, I mean, what's really clear is what works for one community doesn't necessarily work. So we are going to have to make sure our interventions recognise some of that variation as well. And I think that's going to be a real challenge for us, and potentially one where we do need to think very much about taking that community perspective of what's important to them.
Thank you, Jane.
Are we doing my second one, or are you going back to?
I've switched most of them round in blocks rather than here, there, and everywhere.
It's all right.
It's how my brain works, so it's easier for me.
Don't worry, I'm fine. Just so I know. Okay, so I'm going to talk now about population health management. So there's a lot of noise about population health management. In essence, all population health management is the intelligent use of intelligence. And it's as much about culture. It's about a culture that says we build our transformation, our strategies and our delivery plans and delivery on that intelligence and evidence. And that intelligence should be both quantitative and qualitative. So we will only use intelligence intelligently if we enable those debates so that stakeholders own that intelligence and are acting on that intelligence. So we're very much seeing this as an approach that is as much as working with partners across the system, very much clinically led, because this is that conversation about how do you deliver, use intelligence to deliver real change that delivers real benefits and improved outcomes for our population. And that's all got to be about how we make decisions around clinical pathways, etc. And the final thing I'd want to highlight here in terms of this is that we're not intending to build a whole set of population health management and present it and then say that's what you get. Again, this is about working with at all levels of the system, place, ICP, PCM, levels in our health and care system about what is it that we really need to understand, and then we can develop the approaches and the and support that engagement process with stakeholders, so that we are using population health management for real, rather than seeing it as something that sits over there. And that's a bit back to what Steve was saying in the last comment, which is, it sounds lovely, but in theory, but we don't want to build a theoretical population health management framework. What we want to build is a population health management that's being developed for real, dealing with real issues that our system and our places want that intelligence for. So that's really all, Chair, for I'd want to say for population health management. The rest is in the paper and the slide set.
Do you want to just say, because we've been asked to note the successful entry to the national program? We have, and I think this is really exciting, because this is going to give us an opportunity to access quite a lot of support and learning from the national team and other parts of the country. It's a very comprehensive program. It's an action learning type program. It's about building our skills and capability. It has five strands at system, at ICP, place, finance and contracting. So one of the big challenges we've been put forward is that we're moving from a PBR to a much more population-based finance and contracting. So it's about working with our finance and contracting colleagues about how we might use actuarial models and other things to start to think differently about financial benefits and the use of finance and other resources and contracting within the system. And then there's an analytical one. What there will be an opportunity is for a number of PCNs, ICP, to actually be part of action learning sets, which means that they'll be working with colleagues across the country, and it's real life projects. So it will be about things that people want to work on. So what we're about to go out and is sort of, we're just seeking some guidance from the national programme, particularly with PCNs and ICPs, to sort of identify who from our system would be taking part in that. The aim is that we would be looking to start that programme around May, June, once we're out of COVID and people have got enough time and headroom to start to do that work as part of the national programme. Thank you, especially as that's one of the things we've been asked to note about, as well as the rest of the report. Peter?
Thanks, Jan. Thanks again, Jane. I suppose my question is perhaps not something you can answer directly, Jane, but to achieve what you're talking about, and for that to be adopted, and then for that to really influence and shape what happens on the ground, is going to take a huge amount of courage by leaders within the system. So my simple question is, have they got the courage to do the right thing?
I think that's probably above my pay grade to answer.
That's a bit of an unfair question, Peter.
I think that one I'd ask Marcus and our clinical chairs to answer, if you don't mind.
Frankly, I think that's a question more for the entire system, across all boards, execs, clinicians, both at managerial and clinical. So yeah, we'll note that, Peter, and we'll find an answer for you. Unless Marcus wishes to comment.
Just a quick comment. Certainly, given some of the really difficult things we've done, I don't think there's any lacking of either ambition or courage on behalf of the CCGs to do the right thing for our population. Yeah, I would certainly hope the rest of the system and system leaders would think likewise, Peter.
I look forward to seeing that happen then.
And just to sort of move it from, can I say that when we have had these discussions at senior level, at the system level, it has been one of the most positively received, I think, pieces of work at those senior levels, but with a real sense of this needs to be made reality and linked to the practical.
Absolutely, Jane. I think just to comment about clinicians, I think all clinicians work for the benefit of patients, and we absolutely recognise this needs to happen rather than what we've necessarily done or sometimes done in the past. So, Paddy.
Thanks. I'm Paddy Hannigan, GP and Chair of Staffordshire and Surround CCG. I'm also the SRO of the Staffordshire and Stoke-on-Trent digital programme. Jen, I think this is a really great paper, and it's really good to see how far this has come on. We talked about PHM quite a lot last year, and it's nice to see a paper which sort of brings together the sort of ambition and the elements and the partnership across organisations that will give us this, and it could be a really powerful tool as we go forward in terms of how we manage. But there's a but there. There's a bit missing to me in that this and your description stopped at PCN and never got as far as patient or public or citizen. Yeah. You know, the public don't trust institutions with their data, and the data is the intelligence. It's at the centre of this. And the more of that data we can pull together in one place, the better decision making we can make, and the more we can leverage that data to improve care and control cost and improve outcome. But that requires a partnership with the people who think they own the data, which is the individuals. And as I say, we don't have a track record on delivering this. And I think particularly of things like care.data, which had a great ambition, really good idea, but failed because it completely failed to engage the public. I must say I fundamentally dislike the name population health management because there's not a word in there that speaks to the individual, and this will only really work if we take the public with us. And so I think whilst this approach is very much follows an NHSE template, I think there's an opportunity in Staffordshire and Stoke-on-Trent to put our own spin on it, and I think we should clearly connect PHM with the population and particularly demonstrate to the individuals how this is going to work for them at an individual level, because I don't think the data use is about big data and just what we want to do with it. It's about how we can leverage people's data to improve their care as individuals, and I think that isn't clear in our description of this, and I think it will be more powerful if we can sort of join those two things together.
Yes, and I'm sorry if it hasn't, because that is clearly the intention. And when I talk about stakeholders, I don't just mean the sort of professional, organisational ones. I do genuinely mean communities and people as part of that. I think there's two issues there. In terms of ownership, I think it's really important. It's that transparency of using intelligence, not just internally, but to help the population understand why we think these are sort of transformational changes that add value in terms of outcomes. I think that's important at that sort of level in terms of where we are looking to make change, to be using that intelligence much more, not just internally, but with the public. And that is one level. But I absolutely agree with you. Some of the real power about intelligence is allowing individuals themselves to make decisions about care. It links heavily with the sort of social prescribing, social intervention, and with some of the interest our local authority colleagues have, which is not just looking at PCN levels, but really looking at place in terms of neighbourhoods, and how we change some of those conversations to about services being delivered to people, to a partnership between people and services. So absolutely, it's just we probably focused on this because we were focusing on the next few stages, Paddy, of getting this up and running.
If I can respond, I think I know where you're coming from, but the public don't trust us. I think we talk about big data, they think Cambridge Analytica, and we very quickly lose trust. So I think in the way we project this, and it is an opportunity to put our own spin on PHM, but I think our programme should. And I don't even care what, when you say neighbourhood, I'm thinking, I don't care what my neighbours and the people in my street, what is this going to do for me as an individual patient or a citizen in terms of how are you going to improve my health? And I think that's the bit we need to add to this.
Okay, yep, very happy. I'm very happy to have that discussion with you, Paddy, about how we could do that, and particularly if we can link that to some of the digital work. We've already been having discussion about, Stuart, about the digital inclusiveness and the bid, so that we could support some of that work that allows us to do some of this at individual level much more easily. So very happy to have that discussion.
Thank you.
Sally?
Yeah.
I'll take these 3 last questions and that's it.
So I was just, it isn't a question, it's just a bit of a statement building on what Paddy's said. So for me, to make this paper real and for the, given we're in a meeting in public, we need to start seeing a few examples of how it could be used and what it could do to make it a bit more real, rather than sounding something that's very complex analytics and a bit difficult to understand, because certainly I'm struggling to see how it can be used, and I've heard the presentation previously, so I just wanted to make that point.
Yeah, and I appreciate that, and I think the paper was written for a particular audience, and it's also that we're in the readiness phase. What we're doing is pulling a lot of things together to actually start to do something. And that's, I think, why it looks a bit theoretical. The aim is over the next 6 months, this moves from that readiness phase to actually doing some things. And that's why at the moment what we're having is lots of discussions at lots of different levels at system, ICP, etc. level, to start to say, well, what are the key things we need to start doing that start to make this real?
Margie?
Thank you. It was partly to endorse Paddy's comments, but it was also to point out that Stoke-on-Trent did an awful lot of work about population health management and put up databases, had area implementation teams, and had community facilitation services at neighbourhood level, and did a lot of work with residents groups and local voluntary groups in that area to one of the partners at that particular time that was missing from the table was health, but now we've got a wonderful opportunity to harmonise that bedrock at PCN and neighbourhood level, and I think it's interesting as well that Stoke-on-Trent has, around its children and young people strategy, has adopted the Thrive model, which is again services and collaborations around individuals in communities to see which services they need and which support is required at that level. So there's a lot of work already done there that we can build on, and a lot of learning that came out of that, particularly from some of the council members' support in those developments, which has grown tremendously. So I think that there's, don't throw the baby out with the bathwater. There's a lot of learning that's already been done, particularly in Stoke-on-Trent. And I know that because I was part of it. So,
and don't worry, the DPH and Director of Adult Services for Stoke-on-Trent very firmly reminds me that we need to not talk just in NHS models, but about neighbourhoods and communities as well. So absolutely, and they are absolutely. They have provided tremendous support, both our local authorities to developing where we've got to already on this agenda.
Thanks, Jane. Thank you.
I'm pretty sure Lynn Tolley can probably correct me if I'm wrong. Thrive model's been adopted across county-wide. So just for people that aren't Stoke-on-Trent focused. Lorna?
Thanks, Chair. I think I just want to bring us back to that "so what" question, and I really think that what's missing from the paper is the real ambition around what this could be. And I think particularly because this is a public meeting, it's important that we are clear why we would invest taxpayers' money in a programme like this. So I just want to sort of start to set out what my ambition for this programme would be. And that is not just what we talked about here is about using data to describe things, to describe populations, to describe needs, to describe availability of resource, and that is part of it. But in Staffordshire and Stoke-on-Trent, we've always been very good at describing problems, and we've not been terribly good at actually getting on and doing anything about them. So for me, it has to be moving into that predictive and prognostic analytic piece, and it absolutely has to be about walking that line between the public health approach, where we know our populations, we know our patients, we can identify those subgroups that are at high risk or have a need for something or are unable to access something. So we can describe them, we can identify them down at practice level so that we can proactively reach out to them. But also we can walk that line between identification and then intervention. So we can set up a sort of predictive framework so that we can start to look at what happens to patients in terms of the choices that we make as commissioners, but also the choices that they make in their lives, the choices that clinicians will make with them about how they manage their particular health condition. And I would like to start to see us moving into being able to produce tools that we can use with patients based on their data. So that, for example, when you are talking to somebody about their cholesterol level, for example, you've got a page in front of you and you can toggle the little bar across and show them what happens to their chance of having a heart attack or a stroke, or what happens if they, for example, lose a certain amount of weight, if they adopt a particular dietary habit, if we give them a statin. So we have basic tools like that, but we don't have at the moment, but they're quite limited, and we don't have them that we can use with our patients, and that's the place that we need to start to get to. It absolutely has to be that so what about getting into that customised care for that particular patient and their disease course, so that we maximise, we do the things that have the biggest impact on their health, and do the things that have the biggest impact on slowing or stopping disease progression for them by helping them and us to understand that what if. And that is clinically absolutely, from my perspective, where we need to get to.
So I'm going to wholeheartedly agree with you. I think it's incredibly important that, and actually some of the work that's coming out are both across the world and in this country around that, and particularly with the ability to capture data in a way we didn't previously. And the NHS has real opportunities because we are probably the most universal healthcare provider in the world, and the success of the vaccination programme is a testimony to why that has real value. So I think, yes, predictive, yes, things that help people, some of the work and some of the tools that you're already using primary care, I know already, but yes, we can do much more. We can do much more to tailor it. I think that's not just going to be us as a system. So I think the challenge for us is about making sure we start to deliver some of the basics that help people do some of the now, while really tapping in, as you said, to the real power of this, and make sure that we are maximising that learning and maximising our opportunities to get involved in that sort of thing. So, Lorna, absolutely agree with you.
Lorna, just for the record and for the members of the public, can you just remind people who you are? I suspect most people probably know who you are, but anyway.
Apologies, Chair. My name is Dr. Lorna Clarkson, so I'm a GP and clinical chair of Stoke-on-Trent CCG.
And are you clinical lead for the PHM stuff as well? So I guess you'll have a hand in trying to make this stuff real, as opposed to the quite theoretical bit it is at the moment. But I suppose that's the difference between strategy what and the doing how, isn't it?
Yes, I'm really hoping so, Chair.
Yeah. And Lorna's going to be instrumental in making sure we pull together the sort of expertise across the system, and particularly that clinical leadership to drive some of this. Got
loads of them. Moving on, Alison. Sorry, I'm going to have to move on from there because we've got four more items to do in -4 minutes.
Can I be very quick?
Oh, go on.
Go on, be very quick. I just wanted to so I'm Alison Bradley. I'm a GP in North Staffs and the clinical chair of North Staffs CCG. I just wanted to if we're talking about collaboration and ownership, I just wanted to highlight that this has been featured, as Jane has said, at the Clinical Senate, but also on the Integrated Care System board level, and it's going to be regularly reported there. But I think one of the things that's just little bells ringing in my head, and I'm sure it's built into the programme, is when we're talking about actually getting the message out and a clear message out to patients how important this is, we really need a real focus on communications on that population and public level. So as I say, it may very well be a lot further down the line, but really a plea just to make sure that's built into the programme.
No, I take that message, and I think we need to build it in from now going forward as part of the readiness phase. So I absolutely take that from you and Paddy and Lorna about the need to make sure that we're showing how it's adding value.
Thanks, Jane, and thanks, Gary.
Too bloody soft, me. Right. Thank you, Jane, for that. Important pieces of information, important stuff, which frankly we could have done with longer on the agenda, which unfortunately is extremely packed, being the end of the financial year. Since Sally's on the screen, we'll do Sally's bit next about merger.
Yeah, this is a very important item too as well, Gary.
That's the problem, they're all important.
How to put a chair under pressure when he's got a tight agenda to manage. Right, you're doing very well in the circumstances, Gary. Right, so the paper we've put in the pack has got quite a bit of detail in. I don't intend to go through that again. I'm assuming it's read. As colleagues will be aware, a number of recommendations have come out in the white paper, which are due to be implemented if parliamentary time allows by April 2022. One of which is that CCGs disappear from the NHS landscape with effect from April 2022, and the functions of the CCG transfer into the ICS. We don't know a lot more about that at the moment because we're still waiting for further guidance. The bit that the CCGs, though, have done since we had the last meeting in public is the GP vote and the wider engagement with stakeholders. So I'm going to just cover off the GP vote now, and then I'll ask Tracy Shewan to come in and do an update on the wider stakeholder piece. So the GP vote, and as members of the public will be aware too, we held a vote in September 29 where our GPs, apart from Stafford and surrounds, were overwhelmingly against merger. Time has moved on since then, and so has the development of the SDP and the coming ICS. And we were asked by NHS England to go out for a vote with our GPs, which we did at the end of January, beginning of February. The results, I think we were all quite surprised with how positively in favour they were this time. So 84% of all our 147 practices voted in favour, and there was a 94% turnout, which is remarkable because we had to do it virtually this time, which was a bit different to how we did it previously. NHS England have asked us to merge in here by the 1st of October. And some of you will be thinking, why are we doing that if we're going to be moving into the ICS in 12 months anyway? But the reason behind that is to get us more ready as one single CCG to move into the ICS. So in terms of next steps, we have to apply to NHS England, and there is a formal panel where we present our case and a whole raft of documents on April the 26th. Merger is about, it's the wrong term really, it's about disestablishing the 6 CCGs. So as of midnight on September the 30th this year, the 6 CCGs will no longer exist. And it's about creating a single CCG from the 1st of October up until the 31st of March with a single chair and a single governing body. We're quite busy trying to pull all the plans together for how we do this at the moment and working with colleagues, etc., to try and plan some of this out. We're having quite a lot of support from NHS England. There is another area in the Midlands that's also doing an in-year merger, because this process in itself is quite unusual, and that is the Leicestershire CCGs. So I'll hand over to Tracy to give us an update on the wider stakeholder involvement.
Thank you, and I'm Tracy Shewan. I'm Director of Communications and Corporate Services, and apologies, I can't put my camera on because I'm working on a mini hub, and I would sound like a Dalek if I did that, so my apologies to you for that. In terms of the wider stakeholder engagement, we're not duty bound under legislation to consult. However, we all think it is the right thing to do is to engage with our stakeholders, and certainly as part of the policy process for NHS England, we need to know what our stakeholders think and take those into account. But we also need to have the support of our local authorities and our health watches. So that's what we did as part of our engagement. In terms of engaging with the public, we asked them to complete a survey over a period from 22nd of February to the 14th of March, of which we had 53 respondents to. In terms of timing, the overview scrutiny committees didn't meet till last week. We'd previously been to the Health and Wellbeing Boards at the beginning of March, who gave us their approval from both Staffordshire and Stoke-on-Trent. Staffordshire and Stoke-on-Trent overview scrutiny committees were last week, and yesterday we received the formal response from Health Watch. So therefore, the draft document of responses has only just been made available today. So they're going to go to our key committee next week, and we will circulate them ahead of then obviously to the governing body, the wider governing body. So in terms of local authority and health watch support, we have received that. In terms of information from the what concerns our public is very much about that local voice, and it's quite nice that we've just followed on probably from what's been discussed, and Alison raising about that that communication and engagement, because certainly what our public want is local services, and they want to make sure that they can understand what their local services are and actually have an ability to influence. The other area that they raised as an area of concern is about equitable funding, and that's something that we all have to take into consideration when we make our application. So we will be having more discussions about those in details. There was some positive feedback. People are saying, why haven't we done it before? It's a good idea. It'll be most cost effective. Want to see joined up care. So I think you can see there's a theme that's coming through this, and certainly if you look at our strategic direction as a single commissioning organisation, but with our integrated care partnerships, you can see that this is something that the public are wanting, and we need to take them with us. So I won't take up any more time, Chair. We will present that to the key committee and circulate to governing body. It's just in times of sequencing and availability of the report, we couldn't present it here in full today.
Given we're running really late already, any short questions? Given that this is also on the agenda for later, slightly different report, but Peter.
Just a very short question, please, Gary. In the paper, it says that NHS England suggested we didn't do a press release because we didn't want to cause undue distress on members of the public. From what Tracy's just said around the positivity and actually facilitating all the sorts of things that people want in terms of local influence and local services, how on earth was that going to cause distress?
We couldn't have known it at the time. It is their process we're in. We were in a major 4-level incident at the beginning. I've just believed that we may well have stepped that down, but don't quote me. I really believe that's been a recommendation to NHS England board. And at the time, in a level 4 major incident, then really what we're looking at in press release terms is really only about that major incident. So we did make it publicly available on our website. I hear what you're saying, but at the time we couldn't predict how the public would have reacted. They have reacted in terms of 53 respondents, but also in terms of wanting to make sure it was a local issue. But we'll have further discussions on that, how we take all that into account.
Thank you.
Thank you, Peter. Asked to receive a summary of engagement activities to support merger application, and be assured, I think we are. If not, please say so. Lynn, vaccination programme update.
Thanks, Chair. I'll be as quick as I can. I'm just conscious that we have members of the public in the audience today. So just what I wanted to do is just a very quick overview of the programme, how we've got to where we are and what the current position is and what the next steps are. So I'll be as brief as possible. So we started the programme back in December. Our approach was very much as a system, so not one provider could possibly provide this whole programme its entirety. So really, when we talk about integrated care system, this is a really good example of local authorities, voluntary sector, health, all coming together to deliver a common cause. So we set up a programme board with Dr. Paddy Hannigan as clinical lead, myself as lead director, and chaired by Neil Carr from MPFT, that included all of those stakeholders. And we also adopted a very strong programme approach to make sure it was very robust in terms of delivery. We, in the first instance, focus on cohorts 1 to 9, phase 1. So that is everybody over the age of 50, plus clinically extremely vulnerable, healthcare and social care workers and other vulnerable groups. The delivery model had 4 pillars, and those pillars were hospital hubs in the first instance to vaccinate the majority of staff, primary care networks delivering the local vaccination services, which we expected the majority of patients or people to go through. They've been joined by community pharmacy now. We also have our large-scale vaccination centres and a roving model, which was where we had to adopt different ways of working to target specific groups. So the housebound, care homes, homelessness, different ethnic groups. So those were the 4 pillars that we had. It's been quite turbulent. The vaccine supplies have been difficult, but everybody's been extremely resilient, and despite the problems have remained very focused. So our PCNs, our primary care network, started just before Christmas, and literally over the Christmas period, day after Boxing Day, as soon as we got the AstraZeneca vaccine, which is a lot more portable, our GPs were in care homes vaccinating the most vulnerable people. So just to give you an idea of how we've targeted groups based on risk, for every 20 vaccinations we give in a care home, the expectation is that we save 1 life from COVID. For every vaccination over the age of 80, 160 vaccines, and we save 1 life. And as you go down the age range, that likelihood reduces, but it's very clear that adopting that approach set out by the Joint Committee for the Vaccination and Immunisations, that's been based on age and risk, is the way to go. And certainly, as Jane said, we've seen the impact in terms of hospital admissions and mortality in those groups because of the vaccination programme. We've had very high uptake rates in that Staffordshire and Stoke-on-Trent, and that is because we've been very rigorous in terms of making sure we haven't left anyone behind in every single cohort before we've moved on. Just in terms of the current situation, then numbers, we've vaccinated 541,000 people as of yesterday. That's 56% of the total population and 86% of cohort 1 to 9. By the end of next week, we expect to be in the 90% region of the whole 1 to 9 population. Now, You probably know that there is some turbulence at an international level in terms of vaccine flows. I couldn't possibly comment, but what I do know, we are expecting a decrease in the amount of vaccines into the system. So we have capacity to do 80,000 a week. We could go faster, but we're very much reliant on that vaccine supply, and we're looking at quite low levels. So what we are focusing on is cohorts 1 to 9 for first doses, and also ensuring that everybody who's entitled to a second dose receives that dose at weeks 11 to 12. We've been very clear instruction not to go into 10 because of the uncertainty about supply. However, I must point out there will be occasions where we do invite the over 40s into the programme. We've had a number of short shelf life vaccines that we've had to use at very late notice, and we've had to go into the 45 plus range to make sure that we've not wasted any of those vaccines. There will be other examples where we do have to dip into the 49, 48, 47, so we haven't got vaccines sitting in the fridge, but that won't be, be very strictly controlled in terms of have each PCN done everything that they can in terms of reaching out to everybody within the cohorts. Now, I have talked around inequity, so I won't re-rehearse that. But we've not been happy by the fact we've got lower uptake in certain levels, and we've adopted that no one get left behind approach. So high volumes is great, but the low, it's where we've got the small numbers that are equally important because they are individuals that haven't been vaccinated yet. So we've got the programme around inclusion, which I mentioned before, that Shami leads, and very much we're doing lots of work around Asian communities, learning disabilities, SMI, homeless people, and they require a different approach. It takes focus, it takes effort, it takes time, but we have to do that in terms of ensuring everybody receives their vaccine. One size doesn't fit all. So I'll pause there, Chair, given the time.
Thank you, Lynn. Sue Harper.
Thank you, Chair. Sue Harper, temporary PPI lay member for the 3 South Staff CCGs covering for Paul Gallagher. Lynn, I feel I had to say this, and I know I need to be quick, but it's really important. I've attended 4 patient groups in the last month, and at every single meeting, the patients have been so full of praise of everything that has gone on and so full of support for all the work that everyone's been doing, and have asked me to record that at this meeting. So I feel I'd like to do that, please. And also, you don't need to give a reply now, but just a personal concern that I have, having had my vaccine and seeing the fantastic enthusiasm of all the staff there, voluntary and otherwise. I'm sure you have a plan, but we need to make sure that as we slow down in the next few weeks, we keep them interested so we don't lose this momentum when we come back again. Okay, thank you, Chair.
Thank you, Sue. That's really good to hear from our residents. Latif?
Yeah, sorry, just picking up on the point about you know, the staff enthusiasm. I mean, unfortunately, that is starting to present a bit of a challenge now. I mean, with talking about my own PCN, we were given the option to extend to cohort 10 to 12, and the vast majority of practices in my PCN have decided they're not going to go ahead with that. I think a lot of that revolves around the fact that from the beginning of April, QOF will be resumed, and there'll be an expectation that from general practice point of view, it's going to be pretty much getting back to business as usual. There's been a lot of frustration with the PCNs, not just ours, but the other PCNs in Staffordshire as well, about the amount of time that they've spent wasted time contacting patients who then tell them they're being booked in either with pharmacy sites or the mass vaccination sites, and that has been very demoralising for staff. They spent literally hours chasing up, ringing up patients, only to be told that they've already booked elsewhere. And as I say, that's certainly within my PCN, it's starting to have an effect in terms of staff morale, and practices are saying we can't continue at this pace now, which is a shame. But obviously, you know, recognising the reality that we're now expected to start to deliver normal services going forward.
Yeah, thanks to that, Latif. I think out of our 23 PCNs, we have 21 that are refocusing, so 21 are still continuing. Just to give some assurance, we've got enough capacity in the system to be able to manage phase 2. Our expectation was that PCNs, primary care networks, to deliver the large bulk at the beginning, and actually as patients had choice, and amongst the younger population, we call them patients, but they're actually people. People want a convenient time to access their appointments, whereas expectation is that the primary care networks would deliver the vast majority of 1 to 9, and then we'd move towards the vaccine centres for the second phase. Do appreciate the frustration amongst staff. Nationally, they're running 2 booking systems, general practice and the national booking system, and that is causing some issues. But I think this is the biggest, vaccination programme we've ever seen in the country, and there's a lot of learning to be had about how we manage this going forward. And certainly, hopefully, we'll have some more local determination over that to make sure it meets our needs and it's a bit more smooth in terms of the flow.
Simon?
Hi, Simon Jones, a GP executive in the East. Lynn, I just wanted to say we're sort of patting ourselves on the back about the vaccination programme. We look at all the elderly people who've been vaccinated so well, but there's still 15% of social care and healthcare staff not yet vaccinated. So if I was 85 going into a local hospital, there's a fair chance I might be looked after by somebody who's chosen not to be vaccinated. Is there sort of some degree of gentle pressure and persuasion being put on those people who aren't yet vaccinating but are still caring for our patients?
You're quite right, Simon. So we're 88% now of health and social care workers vaccinated, 93% in general practice. But that's not to say that we're not continuing to do that. We've been meeting daily with the local authority to target certain groups. I think that what's coming out of sort of the national workforce lead is that health professionals and care professionals have a duty and a responsibility to get vaccinated, but obviously we can't force people. So we are having those sensitive conversations. Both MPFT, UHNM, Derby are continuing to have those conversations with staff. Our care home workers, the vast majority of care home staff, we monitor it on a home by home basis. We know that there were 2 homes that did have concerns, and that was largely where we were missing people in those homes. And these were younger care workers who had some concerns about fertility. And it just goes back to the kind of granular detail you have to go into. But clearly we're 12% of people yet to be vaccinated who work in health and care. So we have to keep going and encourage people to take the vaccine quite firmly.
I think it's worth noting, don't forget that if you've had COVID, you need to wait 28 days at least before you have your first vaccine, which may well affect health and social care workers.
Yeah.
So it's not all necessarily the individual's fault. I'm going to move on to the next item. I think we are running very late, still got public questions and 2 papers to go, so sorry Latif. Caroline Lawrence, CCG's Progress NHS People Plan.
Thank you, Chair. Good afternoon. I'm Caroline Lawrence, Head of HR and OD. I just briefly wanted to give you an update on the actions from the NHS People Plan that was launched last July. There are 9 different areas of work and actions to progress and to achieve. Some of them are actions for employers, so for CCGs. Some of them are for organisations across the system, and others are for NHSEI or Health Education England. I don't propose to go through all the main areas, the 9 areas, but I would pick out the health and wellbeing section because that's probably where we've achieved the most so far for our workforce, both at a regional and a national level, being used as a case study. So that's really what I wanted to update on. About the actions that have come out and the ones that we continue to achieve to support our workforce, excuse me, from the People Plan. Thank you, Chair. I'll pause for any questions.
Any questions for Caroline? Did you introduce yourself?
Yes. Were you not listening?
I'm chairing things at once. Sue.
Yes, thank you, Chair. I was very pleased to see this report, and thanks Caroline for all the work she's done. I noticed we've just been asked to receive this report. As a governing body member, I actually believe it's necessary to recognise the ongoing work of this of the HR department in this regard, and its continuing work, because we're talking about staff here who have an exceptionally high workload. Most are working remotely, and all are facing a future that could look different. And I think it's really important to recognise at this time the work they're doing and the importance of supporting them in that. Thank you.
Thanks, Sue.
Thank you, Sue. Anne?
Thanks, Gary. Partly to answer Sue's question. This does, the People's Plan is regularly looked at and reviewed and discussed at the Key Committee, but I have actually asked Caroline if she would give regular updates to governing body, because I do think that this is really important and going to be even more important in the coming months. Thank you.
Sally?
Yeah, so thank you, Sue and Anne, for those comments. That's really lovely. I would like to say Caroline's done a sterling job, and she's been off to a national conference to present. Shami Noor has been on a Talking Heads video that is on the national website, along with Jess Taylor, who's one of our admin team. And they're one of only 11 people featured in a 3-minute slot, so they've done brilliantly to get on there. It is really great to be able to say that we are hitting national heights for very good reasons, especially with our staff, because a lot of effort from a lot of people, not just the HR department, has gone into making this happen. And I've got a whole raft of team members I'd like to thank who've really gone for it. And actually, our staff engagement group have been a really great help as well, and we've been meeting very regularly, as governing body knows. So lots of people to thank for all this hard work, but it's really good to see it.
I think it's probably worth recording in the minutes those people and recording their involvement in this as a way of thanking them.
Thanks, Gary.
So well done, all of you that have been involved, because I know lots of you have.
Yeah.
Thank you.
Any further questions, comments for Caroline? Good. Thank you, Caroline. Let you go now. Paul Brown, approval of budget for Q1 and 2. This is an approval item, so
it is. It's been reviewed in detail by the Finance and Performance Committee. So if I could say just a few words, perhaps David Harding, could David perhaps just add to that to give assurance that this has been reviewed, and the feedback that we had at the Finance and Performance Committee meeting on Tuesday from the spending directors of the budgets. So as we were saying earlier in this discussion, our funding outlook looks quite different. In 2019-20, it was a population-based funding method, and that led to the deficit that we saw in the accounts of about 80 million. In the current year, we've moved to more of a top-up situation in the first half of the year, so we broke even. That was straightforward. The second half of 2021 was based on a system allocation, and as you've heard, we've managed to deliver a surplus on that allocation in the half year. Moving to the new year then, in terms of setting a budget, we still haven't received allocations yet. So this is an assumptions-based proposal or recommendation. The National Operational Planning Guidance for 21-22 has actually just come out today. We obviously knew roughly what was coming, so we based this on an assumption that it would be a half year of continuation of the funding regime that we saw in place for 2021, and that is correct. That is what the guidance that's come out today confirms. So we have, in that sense, based it on the right set of parameters. And what we don't know is what our actual allocation is. We've had to calculate that based on what we expect. So it is possible that what we've calculated as a resource envelope is not correct.
I don't expect it to be materially wrong, but obviously it could be, and we'll have to come back to the governing body if that were the case. But nevertheless, we felt strongly that it was important that we start the year with the budget. The new financial year starts next Thursday, so it is important that we approve a budget and give authority to managers for their spending limits. So the allocation for the budget that we're proposing is set out in your packs in 194, page 194 of the packs. A budget for a half year then of 1,017 million, as I say, based on a series of assumptions from last year's allocations that we received. In terms of the expenditure budget that we've set, that's set out on page 196 of the bundle. What we did there was build up a bottom-up approach to the spending requirements. So we looked at actual levels of spend for all of the areas. In the case of contracts, it's been confirmed that contracts with NHS providers will continue with the same mechanism that we saw in this financial year, which is effectively block contracts that have been calculated nationally based on cost profiles. So it looks like our working assumptions are valid. So we're pretty sure on the cost profile. We're reasonably sure on the income. You'll see in this page 196 there is a differential between the two. There is a gap. However, once we then went through that and looked at it and thought, well, actually we've made some fairly hefty assumptions. So we took the long-term plan assumptions around a number of things. The key one being we don't actually need a contingency. In normal times, I would certainly be recommending a contingency. When we go back to payment by results, there's a lot of variability about the cost, and that's why a contingency was needed. It is a national planning requirement that we have one, but we're proposing here to take it out and manage without a contingency. We don't expect there to be any cost variation on our contracts, and that's the main reason for that. A number of other things, the other key one being what we've called a run rate slippage. So if we look at the budgets that we've set, the budgets are based on a number of parameters. Looking at the run rate cost profile that we've seen towards the back end of this financial year, I certainly expect there to be some benefit, as you've seen with the surplus that we've had in the second half of this financial year. I expect some of that to flow into the new year, and so we've taken a view that we can therefore set a balanced budget, which is to break even for each of the 6 CCGs, and that's the recommendation to this committee, that we set six budgets which are all break-even budgets, with a view that with an understanding that we might need to come back and review some of the base assumptions once we get the clarification through. That's the recommendation to this governing body. Chair, David, could you perhaps just say a few words about the discussion to provide any assurance that you can?
Thank you. David Harding, Line Member for Governance and Chair of Finance Committee. Gary, you're chairing a very difficult meeting today, but whether we should allow more than 5 minutes for adopting a £1 billion budget, in my mind, is open to question. I think it deserves more time than that. Having said, given we're in the financial straits we're in as well, that's just an observation on timing of meetings. Let me go back. This particular item had more than 5 minutes at the Finance Committee, be pleased to hear. It had a
precisely, David.
But you need the opportunity to debate it as well. However, having said that, we did discuss the budget rigorously, and at the end would recommend it for adoption. One thing I would draw to the board's attention, however, is the proposal to use matrix management. Now, this is something new, and in my mind, something that can be controversial. And much as I support the adoption of it, I would recommend that we have a dry run on this and try some scenarios and work through the problem solving before they actually hit us. That will help the introduction of that particular part of the budget. Having said all that, given it's likely to be a break even and it's the last budget for us as 6, I would, on behalf of the Finance Committee, recommend it for adoption. Thank you.
Could I pick up briefly, Chair, on the matrix management point? Because I think it's important. It's an important point that David makes, and I think you're right, David. I think there is further work to do on this. I mean, I personally think it's a really important issue. So what we're saying here is that in managing a complex set of budgets that have a number of people involved, but doing that in a devolved way. So what what we're moving towards is a strongly devolved budget and decision making, clinical decision making taking place in the localities. That needs to happen in a matrix way, because there are a number of budgets which span across the whole of the what will be a single CCG, and that's why there's a recommendation in this paper which was discussed at great length at the Finance and Performance Committee around the way that we operate in that environment. David is right. It is a complex concept and one that needs a bit of work, and we won't get right, I'm sure, first time. And I think that is a valid action for us to take away, that we trial run some of that working and then come back and review that once we've seen the results.
Any further questions or comments for Paul, or indeed for David, around what happened at the F&P? Although noting that a large number of people from the governing body do actually attend F&P in any case. Okay, if that's the case, been asked to approve the initial budget for 2022, noting that further revisions are likely as national clarifications, allocations are received. Are we happy to approve it, knowing what we know at the moment? And of course, it will come back if things change. Should I say when things change? Take silence as assent. Therefore, I'm happy to approve that. Thank you, Paul.
Thank you.
Found it. Okay. Any other business? I haven't been notified of anything, and therefore I'm not going to accept anything at this late stage in any case. Meeting effectiveness. Did we achieve what we set out to do? Yes, even if we're half an hour late. Nolan principles adhered to? Yes. Run effectively in line with the meeting's charter? Yes. Is there anything that we need to escalate anywhere or inform of any of our decisions? I think that's no. Anybody's got anything different to say on that? Please stick your hand up. Fine, thank you. So we'll move on to questions from the public. We've got a number of people, a number of members of the public in the meeting. Can I ask, if you wish to ask a question, put your hand up, introduce yourself and ask your question. And then if members of the committee wish to answer, you can put your hands up and I'll call you in. Okay. Sure, we have got some questions, haven't we?
Chair, John Bridges has got his hand up first, followed by Ian Syme.
For some reason I can't see that, but oh, there we go. John, would you like to start?
Thank you. Thank you, Chair. John Bridges, Vice Chair of the East and South East Staffordshire CCG Patient Board. Firstly, I'd like to thank you for having the opportunity to listen to the meeting in actual time, and I'll thank everybody who's worked behind the scenes to arrange that. I'd also add my congratulations to everyone, that's the NHS people here and all our community volunteers in the efforts of the vaccination programme. I hope the community enthusiasm and commitment will be harnessed in the new RCP, RCS structures and thinking going forward, as it's a free resource that in the past has sometimes been well overlooked. My question is to Paul Brown. He mentioned that from the surplus money, significant amounts have been given to the two councils for investment. My question is, how will this investment be monitored to ensure it is being used for its intended purposes? And do we know if the investments will be in areas that are sustainable going forward? Thank you.
Thank you, John. And I'll perhaps just say a few words, and then perhaps Cheryl, could you perhaps just comment on the way that we work with the councils around the Better Care Fund and the Section 75? Yeah, I mean, all the areas, John, of investment are things that had been kind of worked up already in some shape or form, but we didn't have the money to do. So they weren't kind of ideas plucked out of the air. Many of them are areas where we the concept is really one of pump priming. So putting in the investment to test out whether it has the effect that we want it to have, whether it improves the care and frankly also improves the finances going forward. So yeah, the vast majority of that it is effectively an investment in a test bed where we can actually monitor the impact of the interventions, and through the Better Care Fund and the relationships we have with the councils, who are, as you know, now part of the ICS. There's an ongoing process of review of the impact. Cheryl, did you want to add at all?
Yes, happy to. Thank you. I think, I mean, building on from what Paul has said, the schemes we've looked at are schemes that we've worked with the local authority. So I think it's really important to understand that this is not something that we've just dreamt up in isolation. These are schemes that we know can work very well. We've got evidence around them, and they're schemes that the local authority are involved in. So there's a clear benefit to working with them and for them to hold the money via Section 75 to draw down on that, but with us. So I think for me, you know, there's a double win. As I say, the local authorities are very keen, so there are schemes around you know, preventing people going into EDs, schemes to keep people well in their own homes, and they're all things that are currently supported by the local authority. There's a boost for voluntary sector and others, again, very much linked to them. So it just feels the right thing to do in terms of that joint approach, both in terms of commissioning the schemes and supporting them and monitoring them through that use of that money. Is that okay?
Yes, that's fine. Thank you. Thank you, Chair, for the opportunity.
Thank you, John. Ian, have you got your hand up?
I have, certainly. Could I first... I
can't see it.
I'm sorry, Ian Simon, sorry, member of the public. Can you hear me okay?
We can hear you.
All right, so I'll have to go outside and shout and then you'd certainly hear me. I would also like to pass on my thanks for the absolutely magnificent work that's been done regarding vaccinations. Although I think there are certain dangers here, in as much as certain sections of the media who should know better see this as a total silver bullet, and certain politicians who should know better see it as a silver bullet. I think there is still a need for caution, obviously, but it is a light at the end of the tunnel and absolute sterling work for everybody involved. Thank you very much. Right, I have 3 questions. The first is at the Munro hospitals, second mental health, and third on long COVID. First question, the CQC actually published the whistleblower allegations made around Munro hospitals. They've been in several times to the Munro hospitals. And of course, you now stipulate there have been COVID deaths at the Munro hospitals in 2021. In your report, Quality and Safety Report of January, at the governing body, paragraph 171 stipulated a report will be presented in full at the next governing body. A, is the report on the Munro Hospital, paragraph 172, page 91 of 257 in the quality report, is that the full report? Because, no, obviously not, you're shaking your head. So when are we likely to see a full report? I understand the CQC is still reviewing. And B, there's a B section here. I don't know if I misheard, but I think I heard that RCAs have been done over the COVID deaths at Munro.
Yes.
Now, nosocomial or hospital-acquired COVID is a serious problem. Data is published on that, and it, as I said, a very serious problem.
Yeah.
At their March meeting of UHM board, UHM actually published the amount of nosocomial COVID deaths. These are people who went into hospital without COVID, who acquired COVID in hospital. No doubt about them acquiring the COVID in hospital, and there are significant